mind. That's right. So thank you all again for being here for our Region 16 meeting. I'm Michael Allen, for those that don't know me, DA, and I appreciate you all meeting here in the DA's office. With that, why don't we go through and do introductions, and we'll start over here with James.
I'm James Porter, facilitator and principal of Initium Health.
Maya Capolino, Director of Marketing at Initium Health.
Good afternoon, everyone. Chief Dicler, City of Woodland Park.
Hi, I'm Deb Harris. I'm with Sheriff's Office on behalf of Sheriff Wortham.
Holly Williams, County Commissioner.
Tim Johnson, proxy board, chief reading finder.
And then
Tell the chief I said hi.
That's okay, tell the chief.
Yeah.
DA said hi. Lynette Criverson, City Council at Large.
Jake Marcus, proxy for Teller County Under Sheriff, Stan Bishop.
Denise House, City of Manatee Springs.
Dr. Edwin Kinsley, coroner and chief medical examiner of the coroner's office.
Dave Lineover, Colorado Springs City Council.
Steve Johnson, Colorado Springs Fire Department, proxy for chief.
Carrie Day here, El Paso County Commissioner. Michelle Wolf, proxy for Commissioner Erickson.
Communications for.
Deanne Ryberg, interim director at El Paso County Public Health. Kim Montee, director of Teller County DHS.
Good afternoon, I'm Brett Pratt, Lieutenant with Colorado Springs Police Department, sitting in for Commander March. You need to move up here. Got a key right here for you. I wondered if you were here for Mark.
El Paso County Attorney, Legal Advisor, Council, and Mr. Chair, you do have.
Okay, good. You know, I was gonna ask that.
Connie Bryan, deputy county administrator.
Yep.
Amanda Smith, Colorado Springs Fire Department.
Andrew Rose, executive director at CASA.
Declan Thompson, senior staff for the Full Circle Program, Colorado.
United staff with Full Circle Program.
Dr. Roberts, Chief Officer, Operation Office.
College Creamer, Director of Withdrawal Management, now Patient Services.
If there not be questions on the point of chief administrative officer. I'm Bridget Houston, I'm a manager with El Paso County Department of Human Services, overseeing the drug court and non-drug. Henry Lastly, Executive Director, One Chance to Grow Up. Becca Barnhart, Public Health Analyst, with the CDC Foundation.
You got to go walk in the hand. Right.
Leonie Murphy, started the recovery.
Sherry Trinidad.
Thank you.
Eric Bolton, favor together.
Stanley Conley, Director, Open Heart and Open Doors up in Miller County.
Allison Dodd, with One Chance to Grow Up.
Matt Revere, affected family member and member of the non-voting council. Non-voting. Yeah.
Dana DeHura Smith, Director of Community Engagement and Development from Porchlight Health, formerly Front Range Clinic.
Carmen Pack, Porchlight Health, Local Service Director.
Tom Ross, Paso County Sheriff's Office.
John Cottle, interim dean for the College of Public Service at UCCS. Dr. Cottle is how I. Yes, sir. That works too. Thank you. Right, so we've already determined we've got a quorum. So I will, at this point, turn it over to James to take us from here.
Okay, so the next agenda item is a consent calendar where we would like a review of the minutes and then move to approve them if the council agrees.
Motion to approve minutes.
Second. We have a motion and a second. All in favor of the motion to approve the minutes?
Aye.
Aye.
Anyone opposed?
That motion has moved. So as we all know, we're at a very important time in the council work where we are going to be voting on applicants for funding. The central goal of this organization is to push funding out from the opioid settlement funding. There are 3 applicants that have applied under the setting of the MAT MOUD applicants. So we set this up where they would each give a 3-minute presentation. We have their materials in advance. And then we would spend the majority of the time with questions and answers. So they each have 20 minutes. There are 3 of them. The first one is going to be Rocky Mountain Clinics. Okay, as a reminder, here's how we are given directional guidance on how to score them. Their alignment with the scope of work is weighted 30, the organizational experience was weighted 10, the cost proposal was weighted 10, the project sustainability was weighted 25, and then the evaluation of the proposal is weighted by 25. And this is directional guidance. There are things kind of beyond these numbers that you can use to make your final decision. Go to the next slide. So I'm gonna have them present, right before they do, just wanna highlight to refresh the recollection of people who have read the materials and have the information. We also did a webinar for the new members and we looked at some of these same things. So I just wanna highlight that the funding request they're asking for is $100,000 essentially for the continued support of outreach, withdrawal management services and enhanced treatment services. They provide outpatient withdrawal management, they expand outreach to hospitals, enhance treatment capabilities with mobile clinics, and they increase the number of patients assessing medication. Preliminary review highlights that some of the pros of their application include comprehensive care, accessibility, their evidence-based approach, community impact, and established success. So with that, I would like to invite Porchlight Health individuals, the audience, to come up and present. So it wasn't a full-blown presentation they're gonna do, and it's not a kind of PowerPoint intentionally, so. It's really just giving them 3 minutes to summarize their application and then use the majority of their time for you to ask questions to discern how you would ultimately rank them. So with that, you can introduce yourself and dive right in.
Perfect. So thank you, Eric Smith. I'm the Director of Community Engagement and Development for Porchlight Health, formerly Front Range Clinic, currently Rocky Mountain Health Clinic. So there's a lot of names for us that people have heard. So just so you know, we're all the same agency. No changes have been made other than the name. So our proposal is requesting continued support for our outpatient withdrawal management programming. So currently what we have is we've got clinics throughout the state of Colorado. For this region specifically, we're supporting Woodland Park as well as El Paso County through both Fountain as well as Colorado Springs. And then for Colorado Springs, we've set up what we call our outpatient withdrawal management programming, which is a space that's kind of in between, or it's intended for the patient who does not require an ED visit for their withdrawal management, but also is struggling to do this at home. So through this program, we can provide outpatient support for alcohol withdrawal as well as high dose inductions for buprenorphine for patients with opioid use disorder. In addition to this, we're requesting funding to support our enhanced treatment services for the Woodland Park and Fountain locations. Our enhanced treatment services, what this is that individuals are seen by a medical provider at their initial appointment. They get sent home with a take-home kit. So that includes a full socks as well as some instructions. And they get an evening phone call from a medical assistant around 5, 6 o'clock in the afternoon, checking in, seeing how they're doing, seeing if they have any increased symptoms, checking their vitals, and then providing a directive from that point. So directive is to go to the ED, they'll support them with that process. If it's to ask some questions about what, the medication or some of the symptoms that they're having, they can support them with that, as well as adjust any appointments based on their needs in those conversations. So typically, all of our new patients are receiving this support, but it is available for new patients as well as current and existing patients. So if we have individuals who have a return to use or a relapse, they can be put into this enhanced treatment program so they get additional support in the evenings. They can also be put into the program for the outpatient withdrawal management piece. Through this funding, so we have braided funding that we've used throughout the state to implement our outpatient withdrawal program. So Colorado Springs is one of our 7 locations in the state of Colorado that offers this service. We have over 60 points of care throughout the state. We manage the mobile health unit through the state opioid response grant. So we're providing a lot of rural support, and that is where we've received some funding from Diversis to do the enhanced treatment services component of it and some of the other locations that sit outside of El Paso and Tulare County. So this will just kind of bolster the services that we have specifically in this region. Across our system, we accept all forms of insurance, including Medicaid and Medicare. We also offer sliding fee scales for people who are uninsured. That includes people who are undocumented. Additionally, we take a low barrier, high access approach to our care. So we will support people with a variety of services, whatever their goal for treatment is. So whether that is a full abstinence-based approach to care, whether that is just addressing one of their several substance use disorders, we will support them in that process in order to keep them alive. I think that's it. Did I keep at my 3 minutes?
You did a great job.
Okay.
So, now we're gonna open it up for questions and answers to the group based on their applications. So I'll open it to the council to ask the questions if they have any of the group.
Can you tell me more about what's in your outpatient kit other than a pulse ox machine?
So we have a pulse ox that's in that, as well as instructions of different, like various symptoms to look for to then go to the EP, as well as information about their next appointment and information to connect with our provider.
So it's just a pulse ox and information.
Correct. Yes.
I mean,
In total or through this program specifically?
this program.
I wish I had that number off the top of my head and I don't. It was a little bit lower last year than we anticipated. Part of that, we've made some adjustments to how we were documenting it. So they were having some challenges with pulling the information from our EHR. Our EHR is not the best when it comes to reporting, so they recently made some adjustments to better pull that information. So I know that the numbers that we reported previously were not super accurate. And we did communicate that in our last quarterly report about the adjustments that we made and are hoping to be able to provide some updated information about who was actually supported with the service.
And just a point of clarification, I think you're sensing it, but they were previously funded for a cycle.
Yes.
They were awarded $133,000 that first year, and then coming back asking for second year funding of the $103,000.
Yeah, when you were talking about, patients and billing, et cetera, you made us thinking about undocumented. Can you just touch on that a bit, what you're referring to?
Just in terms of if folks are undocumented, they can utilize a sliding fee scale to still access service. So we don't refuse service to anybody regardless of their ability to pay. So that's really what that is. So that sometimes we work with people who are undocumented, who are fearful of applying for Medicaid, or maybe they have somebody in their household who is undocumented and have some concerns about pursuing Medicaid or other health insurance options. We'll still treat those individuals and they can access care using a sliding fee scale. Does that answer your question?
It does, I don't think that people that are legally are eligible in that case, but yes.
Right, they're not. And so that's why I said there's other people like in the household, because sometimes there's mixed status in households. Sometimes people we found are fearful of applying for Medicaid if they are eligible, but they've got somebody in their household that's.
So can you talk a little bit more about how you're getting the individuals referred to you, and then especially the folks that are going with take-home kids? Are you starting them on medication assisted treatments? And if so, is that like precipitated withdrawal? Are you waiting until they're symptomatic? How are you making sure they're symptomatic when you get them? What does that look like?
Yeah, so our providers will, usually it's at that first visit, right, they're coming in. We have specifics for CAL scales, we're walking them through that process, and seeing if they're a good candidate for that induction in the clinic. So we do that thoroughly at every new patient visit, really just to see where they're at, gauging the resources that they might have at home, if they would be safe to do it at home or be in the office. I'd say the majority of our patients are able to do it in office setting and feel comfortable too when they're there. So we've created spaces within our clinics to give them that safety. And then we're checking on them every anywhere from 5 to 30 minutes while they're there in the facility with us, is kind of checking vitals, going through that CALS again.
Providing comfort medication.
We're providing the comfort medication and induction.
How do you manage that if they're out in the county?
Right, can you say that?
They're out in the county, right? So you're trying to extend more into the rural areas. How do you manage that? You have them coming in on that once a week visit that you do up there and then starting it there and then having them go home?
Yeah, so we can start patients anywhere in the state. So what we've seen primarily with like the rural counties, we'll bring them into the Colorado Springs office to start their care. And then they may continue and do all of their outpatient support out of like the Fountain office or maybe Teller County Woodland Park. We have in the past been able to use some of our other funding to support patient assistance and transportation costs for that, as well as we rely heavily on Medicaid ride support, since a portion of the population is Medicaid funded. And then regarding your question about referral, about 33% of our referrals across the system are coming out of criminal justice. And then we see about another 20% or so from behavioral health and other medical supports. And then I would say the majority or the remaining amount is coming from community service providers. So that could be anyone from another treatment provider, that could be a harm reduction agency, that may be an agency that's working with people who are unhoused. So we've got a pretty broad referral network that we're working with. I've always said anybody who wants to work with us and wants to be our friend, we're willing to work with and happy to do that. And we've tried to make our referral process as low barrier as possible as well. So people can just call our 1-800 number and can be seen within 24 to 48 hours. And they do meet with a medical provider at every appointment that they come into our clinic, as well as having access to behavioral health services and psychiatric services specific to substance use disorder.
Can you talk a little bit about, this is a question going on to the next question. You provided pulse ox and then instructions for medication, I think. How does that deal with the issue that we're talking about with this, council?
Yeah, so it's one of the things that we're trying to do is divert people out of the ED for unnecessary leave, right? So there are certainly people who need to be in an emergency department setting for withdrawal management. I don't want to minimize that. However, we do know that there are a lot of people who just need some additional support. They're scared, they're fearful, maybe they've gone through an infection at home on their own and they weren't super successful with it. So the goal here is to one, kind of divert people out of the ED who don't need to be there, as well as providing additional support so we have improved retention and compliance with treatment. If we can provide that additional support, we can call it in the evening. We have seen really good success rates with people returning to their secondary appointment after getting that phone call at night. We've also received really good feedback from our patients about how valuable it was. You know that we've probably all been to a medical appointment that we went to ourselves and then we went home and talked to our partner or a family member and they said, well, did you ask this question? And you go, no, I did not ask that question. And so this has been a really nice space for patients who have been able to step away from the clinic, kind of think about what, you know, they picked up their medication, maybe they run a question about what it looks like or how it's utilized. They can ask those questions to the MA at that point and say, hey, you know, maybe this is the experience that I had. I'm not sure how to, you know, take this medication specifically. I'm not sure I remember what they said. You know, we're working with people who are in active withdrawal. People who are in active withdrawal don't feel good, right? And so we're giving them instructions on how to take medication. And sometimes it's not always, you know, they don't always remember, or maybe they're not in the best place. And you know how it feels to go to the doctor when you're super sick and you get take home care and you're like, I don't know what you said because I wasn't feeling great in that moment. So this provides some additional support so that we can bridge that gap between them receiving the information and then following through in hopes to, you know, retain them in treatment, get them connected to additional services. So if it is that, you know, hey, you're in a bad place, you need to go to the ED, helping support them with that, finding them higher levels of care if that's what it is.
So the instructions are for the medication that is dealing with their withdrawal symptoms and their disorder, essentially.
Yeah, so the instructions are about the medications that they received. It's also any like red flags for how they're feeling. So, you know, kind of here's some things to look out for. If you do experience these, go to the emergency department. So that people know what's kind of normal withdrawal symptoms and what is high risk and needs to be medically treated.
And I'll add, we do call them the next day and then they're coming back to the office or meeting with that provider via telehealth phone within 24 to 48 hours as well. So we're keeping a good close eye on the patients. Been very successful up in the Greeley area up in Polk County as well. They've been doing it up there now for the last 3 years.
So just, looking specifically about what you said success would look like at the end of the year. The goal of serving 15 to 20 patients per month within the region, have you consistently met that goal with that?
We have not at this point with our previous reporting metrics. So, we had some turnover of staff in our Colorado Springs. One of the things that we've identified is that this program is really well suited for more seasoned providers, and we had some newer providers who struggled a little bit with the process. We've done a ton of training since receiving this funding last year to really support the providers who are accessing the care, connecting them with more seasoned providers. The other thing that we did is they were not reporting well in the system. There was this idea that only people who were receiving withdrawal management support were people who were sitting in the office for 8 hours. So they weren't taking into account the several patients who were receiving comfort medications, but were maybe only staying for 30 minutes or an hour or a shorter period of time based on provider discretion. So we've adjusted our reporting metrics to better capture that. So I do believe that we were meeting that goal, but the way that we were reporting it was not accurately reflecting that. So Carmen and I have worked together to make sure that the staff on site has appropriate kind of metrics for how to report that out, and that we're pulling the data appropriately out of our EHR to show, you know, actual number of patients served.
Any other questions?
James and I are on the same wavelength.
They started at 2:09, they finished at 2:24, so that was 15 minutes. Thank you very much for your time.
Thank you. Appreciate it.
The next group that's going to present to us today is the city of Colorado. As a refresher, they have a funding request of $190,000 in front of us today to support the second year of their TOR MAP program. The main objectives provide mobile medication, facilitate navigation to ongoing MAT, serve 230 unique patients within the first year, to conduct regular evaluations to refine the processes. Some of the pros of our application is an innovative approach. They're mobile services. They have no barriers to access, strong team structure, and a data-driven, outcome-based approach. So with that, I'd ask the folks from the city of Colorado Springs to come up and present. This is the second year funding request. The first year they received $198,000. With that, I'll turn it over to Steve.
I'm gonna kick it off and then let Amanda run with it. As I mentioned last meeting for us, this funding came in after all the legal reviews and things finally happened. It took until October for that to happen. So then we started our process of getting people hired. We also had to get waivers from the state. So Dr. Bronski and Dr. Stater, Bronski, our medical director, Dr. Stater from the Oxstone Project worked with the state to get waivers for paramedics to do buprenorphine induction in the field. And then we began to work on the training piece, getting people onboarded and doing that work. And so we actually did not even actually launch the program until February of this year. So we're not even a month into the beginning of this program. This request is really because this is the time slot is really for next year. So this request is for money starting January 1st of 2026. So we've just started in it. We have that funding that James mentioned that takes us through the end of this year. And then we're looking to build on that second year. So this is year 2 of the project. I will let Amanda talk about specifics and I'll hang out up there.
All right, so as Steve said, this program is really focused on being able to provide mobile on-site evaluation and treatment for people with opiate use disorder. What's unique about this program is that we are going to the individual after they've had any type of 911 call for a Narcan or overdose on opiates. So we will go out to wherever the individual is, we will evaluate them, treat them. If appropriate, we will start them on Suboxone. And then our clinical navigator will then connect them to ongoing MAT services. So we really kind of are focusing on the initial treatment. Our treatment is intended to be no longer than 7 days because we do not want to be the treatment provider. We want to be that connection piece. Because oftentimes people after an overdose get missed. They go to the hospital, they get a list of resources, they're told to reach out to a community provider for ongoing care. And what we know about addiction is that people are at their highest risk for overdose and continued use after a reversal. So we want to be able to eliminate any of those barriers by being able to provide that service in person shortly after they've had an overdose experience. We have, make sure I'm not missing anything. So the medical goal is to engage in a single dose of buprenorphine and then to revisit that in person every day for no longer than 7 days, as long as we can eliminate any barriers getting them to ongoing treatment. We really want to provide the warm handoff, so our clinical navigator will be helping them make the appointment with the community partner that provides ongoing treatment. We will provide education and Narcan leave behind for families. that we go and meet with. And then we also, a big part of what we do is we will take referrals from the community. So if somebody comes into the hospital not through the 911 system, they can refer to us, and then we will take referrals from any community partner, private organization, nonprofit. We do not have the barrier of a payer. We're not billing services. So we are able to provide our treatment at no cost and no barrier to the individual that's needing the service. I think the biggest thing that we want to impact, aside from being able to eliminate barriers, is really impact our emergency medical services by hopefully being able to be that support. So if our engines go and run on a call for an overdose, we're able to go there right away, provide the education and treatment as well.
Which we can pick up on. We're moving through with our gelato system, so we're able now in the final process is the automatic response. So we're teaching our fire department to put in the right information so that when they do, it automatically picks it up and refers it back to us, and we get that referral into the system, says this individual had this happen, and then we can follow up quickly with that. And then I want to mention before we go to questions, because I think we're probably up on our 3 minutes. Why did we jump into this space? Dr. Bronski and I have dreamed about this for quite some time, but there's two reasons that I personally felt so strongly about this space. One is for a lot of the individuals that are suffering from overdoses coming out of our homeless communities, and that is a huge barrier to them getting better, right? Substance use. So we're also working within the homeless community as long as many other people on the margins of our society. But if we can get to them through this process or make this available, we can get them into a space where we can help them start to deal with the underlying issues that are driving the behaviors that we see that are really the symptom of the underlying issue. So that's one piece as we look at that. And the other part was, remember being at a CHP meeting, partnership, and one of the folks that worked there talked about her son who was caught up in substance use and was continuing to overdose. And even as somebody with knowledge and means and access still struggling, and it occurred to me that for people who go to the hospital quite often, they go, but if there's no way for them to connect, it happens again and again and again until either they get lucky and they get connected to service or they die. And I thought, we're in the hospitals all the time with what we're doing in our other programs. This is a place we can connect. We can start to pull people out of the cycle and redirect them. And so that's what underlies the heart and the mission. It's meeting them where they're at in those places and now trying to break that cycle and get them directed back out into a life as it should be and as they would dream it would be. Questions? Dave?
So define, like the fundamental differences between this program and the CRT program. Like there's probably some overlap, but how are they used together or individually?
So the together part, any of our programs can refer to any of our programs internally. So if CRT was to come across somebody with a substance use issue who was interested in that, we would definitely want to connect with them, and they can do that. CRT, Community Response Team, for you, those of you who don't know, is our high acuity mental health response team, but they are focused on mental health issues, not on substances. Substances go in a different direction. So that's not their focus, but they definitely can refer back to the other programs, so they would make that connection.
Well, mental health often has a connection
It
to
does.
substance, so I mean, it's hard sometimes to separate those two, so.
And I think the difference too with CRT, they're responding in the moment. So when a call comes through on 911 that someone's in a crisis, whether they have substances on board or not, CRT is dispatching to that. Our program is a 72-hour response. So we are not necessarily picking up those calls to go in the moment. We're allowing medical to do what needs to be done. And then we are going to follow up to say, hey, you had a recent overdose. We want to help you out. These are the things we can offer. We can get you started on Suboxone if that makes sense. And if that doesn't, that's fine, but we can get you connected to community resources, supports, whatever you might need. So ours is more of an after event versus an in the moment.
So it could be CRT refers.
Correct.
Yeah.
Because if it's an active overdose, the engine's going, not CRT, right? Because it's a medical issue at that point.
Sure.
If CRT goes and someone has a substance use issue, then it becomes, is this a person who needs to go to the hospital even though they're not overdosing because it's a medical issue? Because they're not going to treat like with buprenorphine on site with CRT, that's just not an issue. But then they could refer actively over.
Yeah.
And if the team's on, they could call the team and ask if they were free to come in that one time.
Any other questions?
Will your program be impacted by the Senate bill and sorry, 25-192, the sunset of that? I know our community paramedic program potentially could face some impacts with that.
So we are funded through all kinds of different funding streams. That is not one that we're connected to. In this particular program, the money that we're asking for is just salaries and benefits plus a few $1,000s for buprenorphine and some supportive medications. The rest of the cost is all covered by the fire department, by my division. So any of the EHRs I already paid for out of my general ops. Medications are coming out of this, but the other paramedic supplies are coming from my budget. So, everything, all of our supervision, which is Amanda, is already covered in the budget. So we have a lot of the vehicles are covered with what we do. So all those pieces are already built in within our infrastructure. And all we really needed to plug and go on this was, the individuals, 2 individuals, and a little bit of money would help with the medications. The medical maker break.
Are there any additional questions? Okay, hearing none, thank you for your presentation. The next presentation is by Crossroads Turning Point. A reminder, Crossroads is looking for $190,000. They provide outpatient withdrawal management, they expand outreach to hospitals, they enhance treatment capabilities to mobile health. And they also increase the number of patients accessing medication for addiction treatment. Their comprehensive care, accessibility, evidence-based approach, and establishing success. We'll go to letting them present.
How's it going? So we're Crossroads Turning Points. I'm the Chief Officer of Operation and Innovation.
My name is Alice Kramer. I'm the Director of Withdrawal Management and Outpatient Services.
And probably Chief Administrative Officer.
So we have a withdrawal management here at Crossroads. At Crossroads. We're in 22 different counties across the state. We do every part, like from the full continuum of care, from prevention with teens all the way to recovery homes. We have every ASAM level of care, of treatment. And so we kind of do a little bit of everything. In Springs or in El Paso County, what we do is we do withdrawal management. So we serve the hospital, we serve the surrounding areas, we do residential withdrawal management. So last year, we saw 2,082 people in our program that came from various referral sources, whether it's Penrose or the other hospital, Memorial, police, state patrol. So we see everybody. In our program, we've never been able to sustain or have any kind of opioid treatment program there because we've just done withdrawal management. We've tried partners with other providers that do opioid treatment programs like Suboxone or Vivitrol, and there's just been a lot of turnover. There's been a lot of hit and miss. So we've never been able to do it in-house. We do in our other communities. We do it down in Pueblo, and we just haven't been able to find a way to get it done here. So last year, we saw 127 people who had a primary just opioids, and we had an additional 250 people who had opioids and another substance on board. And so those people, the 357 people that came through, did not receive they received withdrawal management services, but not received opioid treatment services, which could have, 1, eased their withdrawal, and 2, it could have led and opened a door to additional treatment. We do an ASAM assessment. We have residential programs, so we would be able to put somebody in a residential program that's 3.7, just 1 step higher as hospitalization. We have the 3.5, which we could refer to. We also have offender programs that are residential programs like the STIRT program. And so we're just doing a little bit of everything in this community. What we'd like to do is we'd like to do opioid treatment services in-house. We already have the people, we already have the sustained numbers that show how many people we're serving. We need to ease their withdrawals. And honestly, our goal is to open that door to more treatment. And so that's really what we're asking money for. We're looking for a provider. We're looking for a co-occurring counselor, as well as somebody that's a care coordinator that could help coordinate the care for all of these people coming through. Alice is our director here, and so she's running the withdrawal management. She's the one that's with everybody that's there, coming through the program, taking the referral sources, taking the emergency commitments, setting people up for the next level of care, working with families. We also, because we're a withdrawal management, we get involuntary commitments there. So the involuntary commitments are housed in our program. And so that if they're going into another program, it would be great to start them on Suboxone or Subutex if they're pregnant or one of the other medications. So that's our whole goal is how can we provide more for our patients that we already have? Alice, do you want to say anything about who you see going in there?
Well, like you said, we take referrals from all the 5 hospitals here in town. We take referrals from probation, parole, police departments, sheriffs, state patrol, self referrals. So we do get a lot of clients as well as, just everybody. We even take people from Teller County. We take people from Pikes Regional and UCAS, EMS.
So currently in our outpatient program, we're doing DUI and we're doing offender outpatient services. But this would be the next level for us. This would be us stepping up and serving the community in a different way, in a way that's needed. I think everybody here is presenting kind of the same issues. We all are struggling with the same issues. We just happen to have them in our care already. I think that's it. I know I took a bunch of pre-workout today.
Okay, that was great. Thank you for the presentation. We'll open it up for questions now.
How did you know I have a question? So looking here at what will success look like? You have successfully measured in the number of patients who self-report their improved functionality since engaging in veterinary services. So I think that's a great first step, but you're mentioning lots of partners and kind of where they're going from there. So what does recovery look like in terms of your program? And you can see improved functionality. What are you looking to see for recovery, even though you know that you may be doing handoffs and those? Because I think this just gets to the point where they're taking medication, they may report something, but what happens from there in theory in your program?
So like, I'll just be totally transparent straight up, right? Like everybody in this room knows, like if we're being transparent, this demographic they're not the best at following up. They're not always gonna go and measuring that. I think when we're looking at that, we're looking at continued partnerships. We're looking at assessing for the next level of care. We're looking for we have a lot of frequent flyers. We're looking for people that are coming in less. And if they are coming in, they're coming in better shape. And so like when we say that, it's all relative, right? So their function may be better, but they still may need withdrawal management services, especially people that are using like meth and fentanyl. So if they come in, and we're addressing the fentanyl addiction, we're gonna see like a higher level. They're gonna be functioning differently. I think recovery is really hard to like gauge. So the community partners, the people that follow through, what we're looking for is we're not looking for abstinence. We're looking for sustained wellness. We're looking for them to reduce harm in the behaviors that they currently have. So it's kind of hard. I know our grant does say that, but a lot of people that go to treatment, we're one of the only residentials, so we're doing a warm handoff to ourselves, or we're doing a warm handoff to another community partner. Sometimes it's to Denver. So, what we're seeing as far as recovery goes, I wouldn't say recovery. I would say we're looking at next level of treatment and better life. Because recovery is kind of a loaded term. So I don't know if we're looking at recovery in the way it's written as much as we're looking at it in are they recovering from specifically what they're going through at that moment? I know that's a lot.
I think our goal is, once we get them involved in that services, we already have relapse prevention groups. And so kind of getting them engaged in, groups or outpatient. We also have, we work with Diversus and provide grants for sober living. So, kind of looking at what their living situation looks like and trying to get the whole continuum of them coming back for services in outpatient, or even getting an outpatient somewhere else.
Or even the first step, like the gatekeeper to everything is an ASAM assessment, right? So trying to get them an ASAM once their withdrawal has kind of like slowed down a little bit and it's not as severe, getting them into an assessment where they can answer the questions, they're feeling better, and we could kind of gauge what the next steps are too.
Additional questions, Steve?
I just need to dig into that a little more, because I'm trying to understand it. So, and hi, Alice. It's always good to see you. And I haven't seen Rob in years.
Yeah, yeah. Because I was
So it's
doing
good
a
to
good
see you
job.
again. You're still handsome. So you talk a little bit here about administer surveys annually, a little bit about patients served. I'm just like Carrie, I'm curious, what is that? Can you dig in a little bit more? Because I think there's some obvious metrics there that would be great to know. How many of them go to one of the recovery programs? You know, what are we surveying for? But can you dig more into that? If you have that kind of like, how are you gonna track that and say, we sent this many people here, this many people here, this many people followed up?
So we do, in our EHR, we track discharge referred to. And so we were actually had a quality improvement plan we did with the Versus, like the first time we started working with them. So we're able to track discharge referred to, so we know where they've been discharged, where they've been referred to. We also put out a survey just in general at Crossroads that has a Likert scale, kind of measuring like, what was your experience like? How did it work? You know, do you agree? Do you strongly agree? All the stuff that we ignore when we go everywhere, but they actually do it a lot of the times when they're leaving. And so we're capturing as much data as we can, but really our EHR is capturing, our electronic health records is capturing that data and kind of just, you know, it's telling us where they're discharged to, you know, what they're, whether they went or not, whether they decided to refuse. So we capture that data in our EHR. And I think we put it out for the community. I think we put like the numbers out. I'll find out where that goes. This is not my job.
Other questions?
You said you had 2,800 people. Was that just in this region?
That was,
Just in El Paso County?
Detox this year, this last year, up until February.
Alice is busy. She's busy.
2024 through February.
Yep. 12 months.
What does, what kind of a prescriber are you going to use? And are they like, are you doing them on contract and how often are they
Yes.
there? What does that look
So we're thinking like, we're gonna, you know, a 1089, what's it called, 1099, then I get the numbers on 1099. So we're looking for a nurse practitioner or an MD or somebody that can prescribe for us, and a provider that just prescribe the medications, because we're just looking at doing opioid medications. That's the opioid treatment medications. And honestly, during COVID, we're doing it in Pueblo. Our MAP program in Pueblo is right next to our withdrawal management. And it's just like amazing. They could come in, they could do their blood work, we could collect everything, we put them, and then more times than not, they're coming back to us for additional services, not just withdrawal management. We've tried to do it up here, and in the beginning, we had success, because we weren't trying to just serve us. So we were bringing in, I don't want to say the name of the agencies, but we were bringing in other MAP providers to come in and work with us. But that was a hit and miss. They had high turnover. Providers are, you know, they're like unicorns right now. They're sought after. Everybody's looking for them. And so, you know, we just had trouble being consistent. And so it never really caught on because, you know, everybody talks, it hit the street that we were doing it and we were getting a lot of help. We were getting a lot of people into services. And then it also hit the street that we were inconsistent, and then they kind of quit asking for the services.
And it's really important to have it in withdrawal management. A lot of these medications, you need to be sober for 24 hours. When people leave or they're returning home, it's a difficult situation for them. You know, they often go back to using before they can get the medications that they need. But if they're in withdrawal management, you know, we are doing vitals on them. We have a controlled area so they can receive their first dose while they're still in withdrawal management.
Well, I'll just say this really quick, like, you know, just using Maslow's hierarchy, right? We're not gonna get people into the next level of care when their basic need hasn't been met. If their basic needs getting high, feeling better, I always say it's like somebody trying to teach you algebra when you have food poisoning, like you're not doing it. And so our people that are coming in, they're withdrawing, we're talking about a better life, we're talking about their families. Their basic need is to stop withdrawing. Their basic need is opioids. And so it's, you know, it sounds great to say like, we're really trying to, but if we can't meet that basic need, you know, a lot of the times they're withdrawing and they just can't wait to get out and use. Or if we can get them into another provider, you know, it's a hit and miss. Are they gonna make it? Are they gonna get in the car? Are they gonna get on the bus? So we try to provide all that transportation. So what we're hoping is doing it in-house. And we're not trying to feed Crossroads. We would work with anybody. And so this is just for us has been, how do we consistently do this like we were in the beginning after COVID, working with the partners that we had worked with? It was working. People were getting services. They were returning for treatment. They were getting assessments and they were feeling better, looking better. People were coming just for the mat services after a while. Like I said, the inconsistency is kind of like where it just kind of fell apart.
First of all, I want to say I've never heard withdrawal being equated to Maslow, so thank you for that. Though very familiar, obviously, I had not ever heard it related to as a basic need, so that's very interesting. So we've talked about a couple of things. You talked about this 2,000-ish, I'm just gonna say ish, because I don't know the exact number here, number of patients in this area that are served. You've talked about, the fact that you do have tracks of discharge, that's not listed here in your metrics. Is that something that, number one, do you have a ballpark of any of those numbers rolling around in your head? And I know that that's a big ask, but if not, is that something that you would be willing to, track and set some goals based on so that we can actually see, to your point, if you have people who are just coming in and getting med services, but then leaving and falling off the wagon again and then coming back and, you know, sometimes I know it does take people several times. At the same point, we want to see, I do want to see recovery, understand that you're a step in that process, but are you willing to track what those rates are of people who are getting into other programs and how successful we can start to see the full picture with those partners down the road?
So pre-workout at the best, we actually know where those things go. They go to Diversis, our MSL, right? So those numbers go to Diversis. They will go to our BOSO, our new behavioral health service organization, which will be Signal. So we actually know where those go. I don't want to overpromise, right? So our EHR will capture that. It will capture the data. Sometimes they go to another program, they pull the ROI. So the ROI is the release of information. We have no way to capture that data from the release of information. We can capture whether we made the appointment. We can capture internally what they do. We can capture with providers that are getting the ROIs, giving us the information back. So yes, we will be willing to track everything we can track, but I don't want to overpromise and lie to you and say we're going to be able to track the people that come through our program and get mat services, because some of them won't sign an ROI. Some of them are going to be homeless. Some of them are going to get with their new provider. They're not going to want to talk to Crossroads anymore. So everything we can track, we will track and share.
But raw data, we can track, you know, if we provide mat services, we can track how many people signed up for those mat services, as well as if they came back to us for continuing care or we sent them to a different mat provider.
Well, and
we can even track like which ones of them do.
And there's a likelihood they would come back to us for mat services, and we would be able to capture that data and keep treating them. And thank you for the Maslow thing. You know, I say that as someone with lived experience who's standing on the other side of it now, who's been there. Like, if you don't meet that basic need, you're not thinking about ethics, values, you're not thinking about children, anything else. All of that is kind of compromised while your basic needs needs to be met.
Any final questions? Okay, thank you for your presentation.
When do we get our? No, I'm just kidding.
I will say this is the one group out of the three that was not previously funded, so this is a first request for them. So at this time, I think we have 3 different presentations. We might put the Colorado Springs one to the side for a moment because they're asking for future funding and maybe focus on the first 2. So we can go back and start with Torchlight and get the comments from the group.
Could we get a report from Amanda on reporting and just the technical kind of side of how those relationships have been going?
So Initiative actually has all of their reporting. They're the ones who've been collecting the data reports.
Yeah, so I think that the data wasn't strongly reported. They alluded to it. You asked a targeted question. It didn't come strong. It was kind of very spotty. And I think they alluded to the fact that they didn't have the hires that allowed them to get the people hired that would impact the population stronger. They also stated they believe that their numbers could have been higher with proper reporting, but currently the reporting didn't wasn't reflective of impact.
James, just so we're clear, when you say they, who you're talking about?
Fortunately, yeah, the first group, yeah.
It's a little unclear to me if they weren't able to do the hires, where the money was spent, I guess. So specifically around tracking the use of funds. Is there any insight on that?
I don't think they left, so I
Right
think
here.
you can bring, how about you going to come back up for additional round of questions?
Yeah, sure. Sorry, can you ask that again? Or state that again, so I make sure I'm answering appropriately?
Yeah, I don't have your full budget in front of me right at this moment, but, because it sounds like some of the is contingent on hiring. I assume the full amount has been expended, but if some of those hires and things didn't happen, how is the money still expended, I guess, is what I'm.
So it was less about hiring as much as it was turnover. So we had more than one provider turnover in that location at the time. So part of that was they had the training to do just the general medical support that they were already doing, and then the additional training for the outpatient withdrawal support. Some of that was comfort level. To be completely transparent with you, we had some pretty fresh providers who were pretty green and new to the space who were feeling some discomfort with it. So we worked a lot. So a lot of the funding was supporting some of our leadership team. So the medical director for the outpatient withdrawal management. And we did a portion of her. So she was not paid in full out of this funding. Like I said, we've got 7 other locations that are doing this. So we've used some graded funding. So we paid for a portion of the medical provider who was providing the service, a portion of the medical lead who was providing some of that training and support. Some of the funding was used. So I had folks from our Greeley office where we've been really successful with this program. We brought them out to Colorado Springs, do some really intensive training with the providers on site. Funding was used for that. We were doing the outpatient, or excuse me, the evening phone calls happened throughout the process, whether they were involved in the outpatient withdrawal management program or not. New patients were receiving those phone calls, so we paid for a portion of the MA, paid for a portion of Carmen, who did the training for all of the MAs, as well as outreach to support our connect with some of our community partners about the service. Like I said, one of the things that we were struggling with was they were only identifying outpatient withdrawal management, the people who were sitting in the room for several hours at a time. What they were not addressing or counting were the people who were receiving take-home and comfort medications for withdrawal support. So there was kind of, part of it was we had some really rigid definitions, or the providers or the folks who were putting the reporting into the electronic health system had some really rigid definitions of what they thought qualified as the outpatient withdrawal management program. And we're not counting all of the people who were receiving outpatient withdrawal support that looked slightly different from sitting in the room, receiving snacks and receiving 8 hours worth of care on site. So that's why, and I'm happy to send updated numbers to you. I've already asked my data person to pull those that have a better reflection of the people who are receiving comfort medication to go home that were still receiving those phone calls. So there was both turnover challenges and training challenges, in addition to we had some really poor reporting that was going through our EHR, and worked with a variety of people on our team to improve our reporting metrics.
So what's the actual data system that you're using, and is it coordinated with other organizations and stuff like hospitals and things like that? Can you just expound?
It's not.
Not.
So anybody in healthcare will tell you that all the EHRs are pretty much terrible unless you're operating in Epic. Epic is the Cadillac of EHR, and it's Epic. We don't have Epic, so we're utilizing RxCloud is the name of our EHR. What we have really struggled with our own reporting system is our EHR. You can pull data that is in specific fields, but in terms of qualitative data that's existing within the encounter report is exceptionally challenging to pull. So we have a data and analytics person who is literally going through chart by chart and pulling that information out from qualitative information in the encounter note, which is exceptionally difficult. Unfortunately, our system does not speak well to other systems. And I can tell you that kind of across this space in this industry, that's exceptionally challenging to do unless you're working with a system like Epic. So typically we can There's some easier, cross communication between agencies for like UC Health. UC Health is operating on an Epic system. So if they've got a good system, sometimes they can pull from us or we can do some data sharing. But overall, reporting in this space is exceptionally challenging. So we have tried to improve those systems so we're in the process of migrating to a different EHR system that we're hoping will allow for better opportunity to pull from those encounter notes and qualitative data. So for example, if you had somebody who, again, the provider said, you know what, I don't think you need to stay here for the day, but I do think that you would benefit from getting X, Y, and Z medication to support you with your withdrawal management. That isn't being pooled as an outpatient withdrawal patient. What it is it's in their medication list. And so part of our adjusted reporting metrics is looking at those updated medication lists for those charts to be able to see, yes, we had 15 patients this week who received supportive medication, who received the phone call, but it was all documented in a qualitative space, which was not being reflected in the reports that were. Does that answer your question?
It does, but in this space, I can tell you that I have not heard a single conversation that use the phrase data. Everybody is talking about data. So, that's the focus that I think that you really need to kind of like be thinking about.
Yeah.
Because everyone's talking about it, because we're trying to measure results. How do we get positive outcomes? How do we get accidents out of homelessness? How do we get, I mean, it's like, we just finished a meeting on another subject and it was all about data. And so, I think that's a place that I'd love to see, you guys upgrade and then find a way because we're gonna be looking, we're gonna want.
Yeah.
Good data.
And we agree, just full disclosure, we agree, and part of the reason we are transitioning out of our current EHR is because our ability to capture data efficiently is not there. It is poor. Our EHR is a limitation to our ability to pull some of these data. And we only have one data and analytics person who is covering all 60 points of care across the state. So, and I have a variety of funding, so I'm constantly in her inbox asking her for additional information. And I appreciated Dr. Archuleta's comment about, some data is just challenging, how do we define recovery? So if we're thinking about, success outcomes in this space, I believe that is relative. For some people, getting their housing back and getting their children back is success and recovery, even if they're still drinking alcohol, right? For some people, full abstinence is success. For some people, never going back to jail is success. And so we've had it's just challenging in this space to really define outcomes in a way that's black and white, because recovery is not black and white. And so I completely appreciate that and understand it and recognize that part of our challenge is our ability to report data, and we are working to improve that.
We have Salesforce and Elixir coming in here in April, May. So we're in a testing environment and hope that our data is going to be much better than what it was last year. And we're able to help build that from the ground up, which has been helpful.
Any other questions? The second round of questions, have one from Amanda.
I was just gonna ask a clarification on funding and expenditures. You guys received half of your payment in July, and then just in March, the second half of the funding went out. And so have you expected all of the funding that you received, or?
I would be happy to, so we keep documentation of month to month because the majority of our funding with other spaces are monthly invoicing. So I'd be happy to share our month to month invoicing that we keep on our side with you. I'm not going to tell you yes or no right at this moment because I'm nervous and I'm going to mess it up. But I would be happy to share our tracking document that we use that shows what operating expenses are being covered, how we're invoicing personnel costs. So we have the good documentation on our site that I can share with you.
Any additional questions? Okay, well, thank you for your second round of questions.
Thank you.
So I think, before we move to the next applicant, many potential options. Option one could be to fully fund the request. Option two could be to partially fund it. Option three could be to ask them to come back in July. The wisdom of this group is that, people get another bite of the apple the same year. First round of applications, January 31st, they could come back in July And then, option 4 could be to ask for further reporting. I think the data question came up and, it was the data that they suggested in the application that they wanted to share that they're not sharing. So we could ask for further clarification of the data and the funding and ask them to come back in July, but I'll turn it back to the wisdom of the group.
Anyone with thoughts?
I like the idea of having them come back and present that data to show that they are, being accountable for their promises and their duties. And I really do appreciate your transparency today. So, and recognizing that data is not easy to collect. So I appreciate that. And that would be my recommendation for the having you guys come back and present that quarter two reporting. And hopefully you guys have some good working with that.
Any other thoughts?
I'll say I agree. I think that's a good solution. I'll be honest, this group is not going to surprise us. I really get a little nervous, to be honest, around when I hear things like recovery can look like a lot of things, including people continue to use. I disagree. I don't think that is recovery. And it really concerns me about future relapses and the true effectiveness at the end of the day. So I understand it's a very complicated space to work in, but that is something that I'm going to continue to ask questions about is when we get to true recovery, because I think that we do need to define it by, obviously people have relapses, that's completely understandable, but I do think setting a goal of recovery, not being continuing to use is very, very important. So those are things that I know I'm going to continue to looking for, as well as whether we are truly getting to that extent. And then my final comment, I will just say, I asked a question specifically around undocumented individuals. This is a very highly politically charged conversation. The state of Colorado does not make any of this easy here. When we talk about what that means, however, I am very concerned about dollars going that are supposed to be for American citizens going to people who are here illegally. However, it does make it very difficult. We understand that you can ask a lot of questions in the state of Colorado. And also I don't, especially when we're talking about in a medical capacity, having people who are going through medical concerns, that is a very difficult conversation to have. So I'm just going to voice that as a concern for me. It may be a concern with all the applications that we see, but since it came up, it was not on my radar previously.
Yeah, go ahead.
Okay, so, completely respect your kind of view of recovery and kind of full recovery for some people. What I will tell you is that, that is never gonna be our goal as an agency. We are a harm reduction driven agency. And so we really are trying to close the gap for people. I've said, I think in this space before too, the number one qualifier for people to find recovery is that they stay alive. And so we are operating in this space where we are trying to keep people alive and well. I can tell you that we work with a lot of partners and sometimes we're not the right fit. If somebody is looking for a full abstinence-based program, we can absolutely support them in accessing that. We can also support them in accessing that. But just recognizing that for some people, we have people who come in who take the 12-panel UA and light up everything on that 12 panel. And so working with them to kind of address the shark closest to the boat, what's most likely to kill them, how can we support them with that, then the next one, then the next one. And sometimes it does take some time. In terms of the undocumented folks, we are not serving like a massive amount of undocumented folks. However, we have tried to do our best to make services accessible to that population as well. So we're not using funding specifically for that population. We've got a variety of other funding that we can use to support that population. I just wanted to mention it as part of our sliding fee scale that those folks are not turned away from care in our space, but they're not necessarily receiving like federal funding or dollars that are coming out of grant funding to support their care. It's just making sure that they are able to access care if they are needed. So it's a fraction of our population that we're actually serving. I would still say about 85% of our population is Medicaid funded. That's primarily who we are working with. So I understand your concern and it's a very, very small. Thank you for the clarification. Appreciate that.
Other comments?
So I just wanted to mention, as somebody who lives in a space where we try to measure these things and do these things, I agree with both of my colleagues here that data is super important. But at the same time, it is like herding cats sometimes when it comes to getting your staff to do it the way you want them to do it. You get turnover. Your systems, you have to work with them, they're always constantly changing them or they can't change. And so I'm very sympathetic towards the challenges of data, but we have to have data, right? I'm also sympathetic towards how does that work out in dollars and cents, which would be wonderful if we could always do that. That's really difficult with some populations to say, what is the bottom line dollar value that we receive from that? If someone's got the answer, please come see me afterwards. I've been seeking that for years. So we do the best we can. In terms of what should we do next, I'm not sure, but I just want to bring up that as somebody who lives in this space, that part's hard. I wish it wasn't, and it's harder than you would admit.
Yeah, it's become a big concern of mine. I did a visit, out with the sheriff's, you know, he says that to get medical records, it takes up to 45 days. And so here they get someone that comes in and it's like, you know, 30. They don't have any history. 45 days.
I support coming back in July, so.
So, do we need to vote on that?
Sure, I'm not sure that you need to vote on that. I think that you had not direction to staff.
Okay, yeah, why don't we do that?
Okay,
I like that idea.
all right. So the direction of staff is to have them, ask the request for them to put another application in July. And then if, I think the request was also for me to work with them offline on data to refine that and to get that as part of their next, kind of deliverables for the existing funding, but setting them up for funding for next year as well.
Thank you.
Thank you. Okay, so the next group we're going to review is going to be, let's talk about Crossroads Turning Point. So any additional thoughts on their request, first time funding request, 490,000?
But I love the concept, right? They've got them in the right place, right space. We know that if somebody doesn't intervene when you are actively withdrawing, that you're very likely to go out and use as quickly as possible in order to address those underlying things. I think it's a great start. I wish there was more, or maybe this could be conditional on what we give, that we had more in terms of how we're going to measure and report back. Just specifically, I think capabilities there, just, we don't have a roadmap for that. I'd like to see a roadmap that's more detailed on results, but the overall concept, I think is a great one.
I think my understanding of our application is it's actually $242,000, right?
Thank you.
The wrong budget was attached. It's 242,550.
Thank you for that.
Do we have access to the budget so we can say, look, I saw the same thing, I couldn't find the budget.
We would take a break and we can come up and pull the budget up. We can do that. Additional questions or comments on this? We'll put the budget in the parking lot. We'll come right back to it after a 5-minute break, but any other questions for them?
Do you want me to speak on the budget?
Oh,
Sure. You got it.
The budget, we've had 127,000 for, key personnel, which would be general oversight. And then as well as one co-occurring commission, difference between just a set clinician and co-occurring clinician is there's like duly due subsidies of mental health. That included also one full-time psychiatric nurse practitioner. And then we have general operating of office supplies of 22 per, I should have been saying by my life. So did you want a $5 amount by line item?
That'd be great.
Okay, so we have general oversight for administrative services, $2,250. Co-occurring clinician with friends and benefits, $88,110. A outreach care coordinator at $21 an hour plus fringe and benefits, be $36,660. A psychiatric nurse practitioner for $125,000 with fringe and benefits. Office supplies for $2,250. And occupancy costs for janitorial supplies, internet, rent for $9,375. As well as a 10% indirect fee at $26,000 for a subtotal of $290,779,000, less the CTP in-kind contribution
of $48,285 for a grand total of $242,494.
So it's a full-time nurse practitioner.
Full-time nurse practitioner with benefits.
No, they're not here.
Oh, I'm sorry, it is. 1099.
Do you feel, Alice,
Yes.
are you gonna have enough work to keep a nurse practitioner busy 40 hours a week?
You know, we don't know that, to be honest with you. Right now, it feels like it. Now that we don't have one, it feels like it. So being totally honest, you know, when you don't have one, you know, and I don't know how this group works, but we're open for partial funding. We're just trying to get this thing off the ground.
Yeah, right.
You know, so we don't know. And I can tell you this, though, we've worked with other programs where we could capture specific data that you're asking us to capture. We're open for that. I'd also just like to say, I really respect what Carrie was saying. I understand that our goal is always to have, you know, we would love everybody to be abstinent. We would love that. It's really a hard sell to me if we're trying to be totally honest about where this is going. So I would just say, like, we try to be sensitive to everybody's journey, and I have a hard time with it because anytime you're looking at it, addiction is the only disease where we're looking for perfection, not progress. And I think progress is a big step in the right direction. And I think everybody's agenda, everybody's outcome is looking different, right? And so that's why I said recovery is a loaded term, you know, like recovery implies that somebody was sick, then they got, or somebody was well, then they got sick, then they got well again, and now they're recovering all those things they lost. A lot of our people have generational addiction. They're not recovering from anything because they don't have a baseline of normal. They don't have a social normal or baseline that says this is sober, this is normal, society norm. So like they would never be in recovery. They would be born into a new world. And sometimes we're helping people be reborn into that new world. And that's part of being culturally sensitive and practicing cultural humility to what they're going through. So I agree with a lot of what you're saying, but I also understand, I would love everybody to be abstinent. I would love that. I'm somebody who practices abstinence-based treatment, you know, but I also want to acknowledge the fact that we do try to reduce harm when that's not a possibility. But most of our programs, we're aiming for that. We're always aiming for the best possible outcome. So just thought I'd throw that out there. And then, no.
So I'm wondering, because I agree with what you said about the metrics, it sounds like they're willing to come forward with more metrics. I'm wondering what the parameters would be for us to ask them to come up with a more detailed plan of what success looks like within the data that they can provide and bring that back to us, because I think I wouldn't want to artificially impose things that they don't feel like they could bring forward, and being realistic. And I do appreciate that with both the organizations, to your point, that the transparency is saying, hey, we don't want to overpromise, which I also understand, but I do think setting some goals, that's what we want to hear from you. What do you think you can achieve? And then that's what we're going to hold you to, you know, what you think you can achieve. That's what we want to look for. So I think I would be interested in asking them to come back with some more specific information that they can bring, that they know that they can bring within the systems that they have. And I don't want to get into a back and forth, and I appreciate it. There's a lot of philosophies around that particular thing, but this is a comment more for the council here. My interest very much is in line with moving towards that abstinence. That's not a surprise, probably not for most people who have been on this council and heard me speak, but I have a very personal connection to a family member who died from overdose and did go through programs. And, you know, it's one of those things that it is a very difficult and complicated, and I don't want to minimize that. At the same point, there's always the risk for that death if we don't get people to that abstinence piece. If we don't get them to where, you know, that next, whatever it is, could be laced with fentanyl, and that will be the end. And so just saying, hey, a reduction and it's good. I mean, yes, we always want to see people move forward. Again, this is just kind of from my perspective to the council. These are the things that I'm interested in, because I just think if we don't move towards that, the next time can be the last time for any one of these people. And we're in a very volatile place with that in our community. So that's my opinion.
Other comments?
I was just gonna say, could I just say, I can tell you, we don't want the data to hold us up. What we can track currently, I know we can track. We can track enrollments, we could track follow-up in those enrollments. We could track where they were sent to, discharge, referred to. But I think it would be extremely helpful if you told us what you would like us to track or what you were looking for or what would be acceptable. Because then we could go back and brainstorm with our IT and say, hey, can we track this? This is what they're expecting. I know with our STIR program, we wanted to hold, which is our program for probation and parole, they wanted to hold a bed. And so we were able to track for them how many people that were on probation with the board came through. What were those numbers looking like? Would it make sense to hold a bed? And it didn't. They didn't have the numbers coming through they thought they would. So we're always open to create the data that you're looking for. So, you know, that's what we can do. We could see if we could do whatever you think is acceptable. We're on board with it.
We can already pull like number of encounters, with the referral case from what the discharge is going to, any type of handouts that we do to other providers or any of our other programs. Pulling those demographics between, or the location and county that they're coming from, the location and county that we discharge them to. So I mean, from location to general, to GI, everything that would come to that, we can already pull as of now.
Is it possible to get data that somehow would show lengthening periods of not using? So indicating that your program is working and people are using less frequently over time?
We also do UAs as well, so the whole duration that they're in our MAP program, they would be doing UAs, we can show the length of time they were not using.
So that would be data that potentially could be.
But probably limited because it'd have to be somebody activating your program, not somebody.
Absolutely, it would be.
Because
Yes, absolutely.
You know, it's, it kills us in that part.
Any other points of discussion? That's what somebody can, bridging back there.
I can just add one thing. I think, because it sounds like you already have some of the data, to me, again, I understand that you don't want the funding to be held up here, but to me, that is part of making the case that your program already is successful, and you already have some of that. I would want to see what those numbers are before, I mean, I'm not comfortable, honestly, to be honest, I'm not comfortable funding this at this point. There's enough here for me to say, hey, I feel like this is gonna be a successful program. So again, I would say, I would love to see some of those numbers of what you have now, if you can just show, how many people are coming in, getting, this treatment, and then those discharges to which programs. That would at least give us a number of, if you're seeing 2,000 people, are 5 of them being discharged to the next step in the program? Are, 1,000 of them? Those are really huge differences that would help me feel really, a lot more confident in looking at the potential overall impact. So I still would like to see maybe, again, I would ask them to come back with, show us what you have now in terms of results, and then commit to that, if we were to fund you in the future. So I hate to slow it down, but I think that that is necessary for me to get to the point where I would feel confident.
And that data could be, we could get, Diversis to send that data as soon as we get it.
That was gonna be my question is, do we need to go all the way to July or can that data be provided in a sooner time frame?
They have it, we have it. Yeah, by the end of the week, we have it.
So I think I'd be supportive with a shorter time frame as opposed to July.
I agree. Yeah, that's what I feel.
Yeah, I think the program sounds really good to me. But that would help get us over the hump. So,
We have a contact you were sending that too.
So, there's two potential options. Option one is to have them come back with that data at a future meeting, potentially the next meeting. Option two is to fund it subject to them presenting us acceptable data. And you can, and it might be in a third option. So is there a preference of the group?
well, I think that, from my point of view, I think I would be fine with doing partial funding and then full funding once we get more data. But I know there's maybe other thoughts on this too.
I'm kind of in favor of, I want the data, I agree.
Yeah.
I also want them to be able to get rolling, because I think it's an important piece for our community, because that's where people go to detox and you go and meet them where they are. And so the biggest opportunity we have is in places where we're meeting them where they are. I'm comfortable with, we show us the data, we'll fund you, I'm comfortable with tiered, I'm comfortable with, you know, a sliding scale, if you will, going up as you bring the data, and then as you get the population, you know, more comes or whatever around getting people fully staffed, but I think we need to do it.
Yeah, I think that, I think detox is one of the weak links that we have in our community, clearly. And, you know, to allow the perfect to get in the way of the good is what I'm kind of like concerned about here. Of course, I want data. You heard me say I want better data.
I didn't hear you say that.
But it's like, you know, we don't have a lot of good choices in our community right now. And so, I mean, if this can help a little bit in the moment and now, then it's now, right? Versus just waiting on the data. That just kind of seems like let government slow down the ability to help.
So are you saying 50,000, 100,000 now, and then review the data next month for the others?
What are the good options? I'm not an expert to know what that might be.
When's the funding period start?
So the application period was, they applied in July, and the funding is to go after we make a decision sometime this period. The next round of funding starts July 31st. The applicant starts July 31st. So anytime between now and before the next round of funding is funded, which would be after July, they're applying in July, would be an appropriate time. But I know it's also the wisdom of this group to try to get money out sooner than later, so it's really.
Let me ask a follow-up question to that, and this is probably for Amanda. If we decide to wait to do any funding until closer to that July date, how quickly does that turnaround happen typically? To start actually getting payment out if
Are you asking, like, can you tell me what day, like, I want to, how long it'll take the county to process that?
Yeah.
Usually a couple weeks, we just need to get their W-9, get them set up. We run checks every Thursday, so it just takes a little bit of paperwork to get all of it put together.
So if we essentially kick the can down the road some period of time, we're still far enough in advance that we're not going to impact the funding year July to July, basically. Depending on when we kick it.
Yeah, I think my understanding was that the funding year was not going to be in July to July, that each of these entities would have a different funding year based on when you guys chose to
Yeah,
fund
but
them.
for these, if it starts in July, then it'll be that.
Yeah. If you decided to fund them in July, well.
I guess,
To address that at the June meeting or later.
so why couldn't we ask their team to bring back data and supply it to, and then we look at it the next meeting and go, okay, because I don't think it shouldn't take that long to look at it, and I hate to kick it down the road, honestly. It's like, we got 2,000 people a year going through. I mean, we're missing hundreds of people. Yeah, we're not.
Well, a key component of what they needed was to hire a nurse practitioner with a mental health emphasis, and that's gonna be very, very difficult.
Yeah.
At 125,000, and I think they at least have that guarantee they can start looking, because that is gonna be hard.
Yes, it'll be very hard.
I just want to say though, and I'm comfortable with looking at the data at the next meeting. You kind of mentioned like, you know, do we want to fund them or fund them partially? And I just want to say, data for the sake of data was not my hope. I mean, if they come with, you know, 5 people or, I know that's not the case, but if they come with 5 people are being discharged to the next, you know, kind of step and where they need to go versus 1,000, those, I don't think it's just that we need, hey, send us the data of what is happening. I think we need to look at that data and go, yes, we think that this program is worthwhile. So I'm more in favor of getting the data and then making a decision, because I don't think that what the data says is irrelevant. If that makes sense.
But I'm not sure.
Yeah, I don't think anybody's saying the data is irrelevant.
No, no, we don't want data. I think, but I would say that we need a good eyeball on what it is we're going to measure. Because from my understanding, they're not doing this work at this point. They're handing off people to diverses. But they're asking to bring in a nurse practitioner in order to start medication on site, which is something they're not doing. So they don't have any data. As I understand, you're not starting anything on site, are you?
No.
So they don't have any
Not
data
yet.
to provide with that name. Just their connections, so we don't have any hard data to look at.
No, you're still not in El Paso County, but you are other places. Correct.
We are doing that.
So we could glean from what they're doing in other counties, I guess, is my point.
Like in our, what location of how many
We stand up, I can hear very well.
Program, would that be?
So she's saying, what she was saying, are you asking how many people are going into our MAP program? We have the discharge referred to now for El Paso County. We can get you like what, Pueblo's gonna look different, right? We can show you what we're doing in Pueblo, how many people are coming from our MAP program. It's a newer program. We do have that data, but I'm gonna tell you honestly, like, we are going to have a hard time finding a provider. We kind of do need a guarantee to start looking for a provider. We're not even asking for the full funding. We're saying to even do this, and you're right. And especially as passionate as you are about people, every second that we are not, people are coming through without services and we could lose lives. And so I'm not trying to guilt trip you, but I'm just saying this is important to just, so we can start looking, because even if we gave you the data, we could still be far off, because we are currently looking for doctors right now for some of our other programs.
With what you just described then, if we decide to give partial funding, what would be a realistic, dollar amount for you all to be able to go track down a good candidate? And please stand up when you talk, because you don't have anything here.
I'm sorry, excuse me, it might make more sense to come back to the front, sorry, second round of questioning, just so we can get it on the camera and everything's a lot, yeah, I'm sorry, yeah, if you can, sorry, I said that earlier.
Rob has a big booming voice. I have
Sorry.
tiny little.
It's actually my ears.
Oh.
Yeah, so.
Sure, it would depend, if you wanted to do on a prorated basis of, like, you know, a quarter of it, just so it would give us the first 3 months, that would, I think, would be substantial. From a line item standpoint, if we could just guarantee the nurse practitioner for the first 3 months until the final decision is approved, we're open to whatever, to your discretion. Nurse practitioner would be the emphasis, but if we could continue with the whole budget, at least we could start hiring our co-current clinician. I can tell you, we probably have 4 or 5 of those positions agency-wide open currently. So they're a little harder to have a master's degree in LPC. So, my recommendation, would be for at least the first quarter of the budget. So that would get us through, would that be June? June's your next meeting? June with the,
We have a meeting in May.
oh, right. So if we're gonna already present May, it would be probably like 2 months.
We have a meeting next month as well, so it's a monthly meeting.
Oh, yeah, April.
Yes, right,
Yeah.
so in 30 days, you could come back with that data,
Sure.
potentially.
I'm just saying, what I was saying is kind of what, it's gonna, even if you gave us the money right now, we're gonna have to go out and find a provider. And so the sooner we can start looking for a provider, the sooner we can start offering service. I'll just be honest, we're gonna do this regardless. We're gonna try to figure out how to do this. We need this so we could do it now and not later. This is a need for your community and we want to provide this service. Help us provide it. It's getting done though. We can't not have it. So we're gonna just keep knocking on doors in the meantime. So, you know, this is the opioid response. This is exactly what we are doing.
So it sounds like what you're describing is that the certainty of funding helps with the recruiting, because nobody's gonna jump on if they're not gonna be funded, right?
Yeah, yeah. Even 3 months is better than nothing. Like we could tell somebody, hey, we want to bring you on. We don't know if it's gonna last, but
And then if we have the certainty as a 1099 contractor, we could just put an option to expand, so that way they know very checks aren't coming in, if it's a 3-month or a 12-month project.
So I just want to make a comment on that too. The sooner that they have a nurse practitioner, the sooner they can start being billable and bringing in money of their own and not relying on us. And so I think that's why I suggested that, is because then they can get more on their own once they have a provider that's billable.
I'm just gonna be straight up. We've done a lot of this without funding from El Paso County. We came in, the hospitals were funding our withdrawal management. We came in without that help from the hospitals. We had something from the, Colorado, what was it?
Colorado Health Foundation.
Colorado Health Foundation. Other than that, we've come in and we've showed that we could serve the community with very little funding, very little help. You know, we've had help from Diversis, but we've come in and shown that we could be sustainable. Our goal is not to rely on you for funding. Our goal is to be sustainable, because we know that it goes in waves. It comes with the political landscape. And so, you know, our goal is to always be sustainable.
When did you come in and start doing the work without the funding? When did that start?
When it left the jail, you were.
2018.
I thought it was for a year.
Yeah.
And then we're Medicaid, we bill Medicaid, so as long as they're Medicaid eligible, whether it be the fee for service, on fee scale, on where we can do case management, group, individual therapy, dosing, all of it, they're already set up to do all of that.
I would be in favor of some sort of partial funding and have it come back with more data to be further supportive.
125,000.
I don't know what everybody else feels about that. I know where Carrie is.
I just don't think, well, respectfully, I understand all the timing and all these things. I think spend first, let's do something without having actually looked at it thoroughly makes me uncomfortable. I think taking the month, looking at the data is a more responsible way and not just saying, let's throw money at it and then we'll see if we feel like it's good. I don't think a month is too long to ask. I do think that it's important and that to me is more, I don't like to make a decision without feeling like I have those numbers in front of me. The group may feel very much differently. I think it's a really good program. I think in a month, I'm gonna go, yeah, I like this. But what happens when we come back and go, gosh, these numbers don't look anything like what we thought? And that's, again, that's just maybe my bit more cautious approach to spending dollars once we actually have the information in front of us.
I would just say this, I've been on these meetings since the beginning, when they first started talking about getting this funding. And I don't want to get on anybody's bad side. We're getting funding. El Paso's been slow to the game. Like, we have an opportunity right now to fund a program. We know we're gonna have numbers. So, I mean, I'm just saying, I've been on those AG meetings where we're like, let's go, let's start.
Paso County is very different than most of the state, and I'm very happy about that. So
Yeah.
I'm just gonna point that out, that we do a little differently here, and we're a little more responsible with dollars than many other places.
And I don't disagree with Commissioner Decker. I mean, I know from personal experience owning a medical clinic for 23 years, it's very difficult to get a provider and your sources. So I don't have a problem getting waiting for the data either, a month. I don't think we should go more than a month.
I agree, I'm not, and I wouldn't suggest that. Again, if the group decides that they are comfortable with that, I'm personally not comfortable with making fun of this. All I'm saying, I get it, I understand where everyone's at.
You want all the data set ahead of time so that way it can be distributed accordingly, or does it get sent?
That'd be great. Yeah.
At a time.
That'd be wonderful.
So what's the consensus of the group then?
Wait a month. 30 days.
Big speech for everybody.
No problem.
Is this another consensus question? If it is, I'm with you 30 days.
Motion on the second, wait a month.
Well, we're not, if we're not
We're
voting
just
on
putting
it.
ahead, not.
Yeah.
no.
Yeah, if we're not voting on it, we're okay. They're just, that's why I'm gauging the temperature of the voting block.
So exactly what we're hoping to find in the data, I guess. I mean, it's not the end of the world to wait a month, but I don't know what we're expecting to find that's going to be a determinative decision point for us to say yes or no on funding. I feel like we're comfortable in delaying. Well, I don't like the waste of money. I'm with you on that.
If they
Because-
come back and say
but-
only 5 people are moved into a discharge, and again, I don't think that's what's gonna happen, then I would say, I'm not sure I'm comfortable funding this. I have no idea.
Sure.
So that's what I'm looking for. So I can't tell you in any way, shape or form what it is. I can't give you a number.
Well, I can tell you the verses wouldn't let us be flying.
Like, use the data would be helpful. Because I mean, we can give you our ratio of how many people are, or how many patients are discharged from our publication right into our MAP program, just from a ratio standpoint. And then, I believe the number was 127 patients in the last or 12 months, February to February, were primary opioid users that were discharged from our management. So then we can start making the connection based on the ratios. So again, it's a program that we don't currently have. Again, the parameter of exactly what you're looking for is very helpful.
Well, here's the other question I would ask that you asked. What are you looking for? Diversis is already holding us accountable for what we're doing. So we already have an MSO currently holding us accountable. If there were 5 people moving into a different service, we would have it head on the chopping block. I don't think 30 days is the end of the world either, but what are you looking for? Because, I mean, we're gonna show that we haven't had an ability to do anything what discharge referred to.
In the last 3 years, us partnering with Diversus and putting people into sober living and them helping with funding for sober living for the first month, I think we put 1,800 people in sober living.
But I understand it. I don't want you to be irresponsible. I'm just saying.
You know, that's 3 years and that is documented, and Eversource has those numbers. We definitely like to use the resources we have, and the more resources we have, the more service we're gonna offer to people.
So as I understood it, you're gonna ask staff, me, to, get the data from them. I'll work with you on the data to make sure it aligns with the goals, our overarching goals, and there's a dashboard that, shows how we're having impact on the needs of this particular community. I'll get that data to the council, 10 days prior to the meeting, so they can review it. If you have time, we'd like you to come back to the next meeting if they have any follow-up questions. Yes, it's the last Wednesday of every month. Yes, okay, I'll get that to you in advance. We scheduled this the same way. Would that work for this group?
That's fine.
Okay.
Awesome, guys. It's been a privilege. Thank you.
Yeah, we'll be here. We'll see.
Okay.
Thanks for all the tough questions.
See you next month.
Thank you.
Thank you.
Okay.
You can send your.
Just tell them.
I might have one had by clerk's office over here.
Okay.
But James, the next meeting for them is actually April 23rd.
April 23rd. Thank you. Okay, that concludes our first round of, candidates for our first target area. Let's go back to the, I think that as we are at the point of the agenda where we're looking past the 310 strategic planning section, we're gonna talk a little about the youth prevention applicants. Prior to doing that, I wanted to say that for the next round of applicants, this learning for me is a couple of things. One, to make sure that I instruct them in advance to go heavy on the data as part of their presentation to us, and some of them in the audience who are aware of what's coming. Two, I'll flash on the screen the budget, so you can have knowledge of their budget and talk to the budget in targeted ways. Is there anything else you'd like to see as we bring the next round of candidates in next month?
Just to have the right numbers on there.
Yes, I'll do that. Sure, I'll do a double check on that. Thank you.
Just before I read it, probably not in this round because the applications have already, we've already reviewed them, but for the next set, I would suggest either have a word limit or word max, because some of the applicants were really vague, and then some of them, I am like going to sleep trying to read through all of that information, so I would just a suggestion is have some sort of word limit on that.
We can do that. I think a lot of, it is like they have to put it into like a area, so we can definitely put a word count on it. So we'll come back to that group in the next round.
And the data needs to focus.
Yeah.
Oh.
I think that's one of the challenges with the first round of data is that, it was just self-reported, whatever they decided, and then we get to the point where you ask targeted questions and it's hard to answer. So I think that, the outcome focus of the data, I'll communicate this to the next round of applicants. Anything else we wanted to see as part of it? Okay, so, the plan was to look at these next, 7 applications. They were a total of 7 proposals received. We have a decision point before we even start it is one, we could just invite all 7 to come and present next week. Or we could say, next month, or we could say, we're gonna spend time today weeding some out and ask a smaller subset of the 7 to come present next month. Before we start talking about the groups, does anyone have an opinion on whether or not we should invite all 7 to come back and present, or should we have a smaller group that has to come back to present?
I would say based on how long it takes to get through 3, we need to weed it out today.
So a question I have is, do we have to have them all come back on the same day, or can we actually spread them out?
We can definitely spread them out.
And the reason why I say that is, I actually think there's a lot of value in the questions that we ask of these people. So if, as opposed to just weeding them out because we don't like what's on the paper, it'd be better to hear from them and answer any specific questions or concerns people have.
Preserves equity too.
Say that again?
I think it preserves equity.
Yeah.
I thought the presentation piece is fine, it's just you can get, as like in the last one, you get diverse opinions, that's what slows it down, so. But that's
okay.
good,
That's
those are
okay.
good things. So I think, I wouldn't have a problem with having all of them come and then just see what happens.
I would say, I think that there's some that I'm a little curious on exactly how they fit in, and I feel like I could learn more from those questions, so I
I would be interested too in breaking them up and not having them all at once. There's also the bucket where we did not have a lot previously, so, and it was our largest bucket, so maybe it is worthwhile if there is value in each one of this, rather than try to artificially leave them out, although I agree, we can't do them all at once.
Okay,
Yeah, so I would break them out over 2 different months.
Okay. 2, 3, 4. Okay, so it's 7, maybe 4 and 3.
Yeah.
I do want to highlight that we're gonna have a pending issue when we get to the community prevention and education of 8. And then the recovery is 16. So at a certain point, either we're gonna let everybody come in the same way, or we're gonna weed some out at a certain point. Not
Between
this
now
way today.
and then we just ask you to figure out ways to slow time.
I think that they're quality organizations and applications though in this stack. I can't say that of all of those
Fair,
other ones.
fair.
I think if we make it to the point where it's much easier to go, okay, we really just don't think this one's going to fit.
That's fair.
But maybe it's just an exceptional, batch of applications, because it did seem, I thought, good overall.
Great, okay. So with that, I will, just flash through these are the groups. I'll double check the budgets. There are 7 of them. I will work offline to ask the first 4 to come to the next meeting on April 23rd. I'll work with them in the background. I'll make sure that they have the data that they want to speak to in advance. I previously didn't, the people presented today only shared their verbal presentation, not a PowerPoint, and they also had their budgets in advance. I will ask this group to, since we're hyper-focused on outcome data, I will ask them to see what data they can provide me, maybe 1 slide. So we have the data, the budget, and their presentation to compare against. That sound fair? Please.
Sorry, I know, I have so many opinions, but, one thought is though, they're obviously listed, I don't know if this is in the order in which they submitted their applications, but something to consider is, does it make sense to group them other than just 1, 2, 3, 4? Are there some we're more interested, or some that, because remember, when we get to that bucket, if we fund a lot of the early ones, then, that potentially leaves less. So I just don't know, do we want to do 1, 2, 3, 4 and 5, 6, 7, or do we want to talk about, hey, we want to see these ones first and then these other ones second? Just a question.
I don't know. I think just the first 4 and then the last 3.
Question?
I'm sorry, I just wanted to point out, April 23rd is our next major event, Light of Hope. So it would be super difficult for us to come present on process on April 23rd.
So we could push you to the next,
that
we'll
one
split.
down and
Okay, we'll split.
If
Okay,
that's possible, that would be amazing.
great, thank you. Okay. Please.
Can you remind us, it doesn't have to be today, at the next meeting when we're looking at this, how big our bucket is
When you say,
for that topic?
oh, so these are the 7 applicants for this topic. There were 3 applicants for the previous topic today, which was the MOU. And then, oh, I did fine, dollars and cents. Okay, yes, okay. So I'll have that as a starting point. Thank you. That's another data point, a starting point. How much money do we have? Okay, great, thank you. Anything else for the next meeting?
I think it's helpful if you include the total funding request. I think that's how we did it in the past, but, basically, here's the bucket. If we fund all of these, here's how much we would spend, because that will give us a kind of a way to think about that if we're going into second round.
Gotcha. Okay, so just to make sure I'm clear, how much money is in the account to fund? And then I can work offline with Amanda to see how much is for this cycle versus the next cycle. Okay.
And then I think if you put on, I think if, here you're at, like, okay, youth preventions, there's 7 total requests, 3 million or whatever, right? So if we knew that for each one.
We could know, could we fund these all if we wanted to, or
Right.
would that not be possible?
So they're historic, I'll let Amanda speak to this, but
Yeah, so historically, when we did a prior, 2-year plan to submit it to the state, there were funding amounts put in those buckets. Because that's what we had to submit to the state to be able to pull that funding down. As we got additional funding and we pulled additional funding down, those buckets have changed. And so there is an amount in each bucket, but I just for council to remember, that's very fluid and flexible for you all. You could decide, oh, we want to pull additional money into this bucket or whatever. But then also keeping in mind that all of this funding is front loaded. And so if you want a longer period of time to spend it, you might want to save some for a rainy day.
Understand that we have the flexibility. I just want to make sure we kind of keep in our head, here's the number, and if we want to pull more over, we can, but know when we're approaching that.
is what I think I'm
And
getting.
we're just, I think we're on the same page as saying how much is in this pool, right? And how much is the total ask and how much do we have?
So I work up on demand on that.
Otherwise, we're just kind of, yes.
Yeah, okay, great. With that, we're gonna move to a, break for 10, so we can keep going, I guess. Anybody want a break? Usually the answer is no, the answer is no again. Okay, we'll go to the, Regional Opioid Abatement Council Finance and Contracts Update, Amanda Grant.
All right, I'm gonna tackle. Give you guys one to keep for your records.
Thank you. You care if you want to get in, you don't care, right? You didn't care today, but do you care to present?
I don't care, I'm not.
Thank you.
Okay, so this is the expenditure funding report through the end of February. You can see that we haven't pulled in any additional settlement dollars. In 2025, there's just been the interest earned of $80,000. Under the contracts and grants expenditures, you can see that the additional 1.5 million was sent out. That was that second half of funding that went out in the beginning of March. So those are the applicants that you funded to do 50% in July and 50% in March. So those checks have all gone out. The only other expenditures so far are just our facilitation services. And yeah, that's it. So there's just over $10.1 million sitting in the bank account that's available for appropriation. There's 11.1 sitting. We're saving that other $1 million for additional facilitation and fiscal agent funding for the next 18 years or so, because council is expected to be around long after Mr. Allen retires. And there is an additional $6.9 million in the cost account at the state level. So if you guys were to decide you wanted to spend all that money, we could submit an updated year plan and pull that down. So there's about $17 million available for Region 60. Again, just keeping in mind that all of these settlements are front loaded. So a lot of these manufacturers, they settled it out, they just want to pay it, they want to be done. Some of them have a payment plan over the next 15 years. The longest is over 18 years, which is where that number comes from for how long that this council is expected to last. So just balancing, putting funding in the community quickly, but also the longevity of the program and thinking about those later years when we might only get a couple $1,000. Anyone have any questions on our report this time?
So
I know.
do you have any outlook, like what it might look like next year? Is there just like any, like, you just don't really know?
I don't have a crystal ball. We
Yeah.
don't have that in our shop. The state is working on trying to put together like some dashboards to kind of forecast some of these people who are settling out.
Yeah.
They've got a little bit of that, but it's really hard because just as these lawsuits get settled or people decide to go ahead and settle them, sometimes the funding just shows up in my bank account and I didn't even know it was coming. And I'm like, where did this money come from? That happened with 2 settlements, but they got ahead of sending the email that they had settled it, and so I was trying to find why I got money. But I can work with the state to see if they have any additional forecasts and bring them to anything, but so far, it's not been an easy thing to fix.
I mean, it's, once the funding crashes, you know, it's nice to know,
Yeah.
you know, more than the day before.
Yeah, absolutely. So I mean, to date, we've received about $18 million or so. There's an expectation of about $150 million for our region over 18 years. But that number changes constantly too, as additional parties are added to a lawsuit or things are changed, so.
I wonder how many of these people will still be here in 18 years.
I was gonna say.
I'm not sure. Jake's
Jake's, yeah, Jake's, you're young, you'll.
I'll be the only one.
I'll move this meeting along.
Some of you have more potential, some of us are short. Move definitely here. I do have a question.
Yes.
For clarification, under the facilitation services, 2025 actual, $24,609. That is January into the end of February, correct?
That is just the January invoice.
Oh, that's just January. Okay, so about 25,000, I know I'm rounding up here, for January. Am I reading it correctly that our total, contract for 24 was 133,720?
Yes, and so our second year contract is very similar. Do you want to speak to any of?
Oh, yeah, no, for January is a heavy month because we had all the applications come in and then the review of them. So I think at a future meeting, I need to come back and talk about kind of the initial terms of the contract versus what's occurred in terms of increased hours spent. I think this happened last year, but I didn't address it. I just kind of let it go. But I think in the future meeting, I'm gonna come back and talk about what's expected and then the kind of when we're going to hit a certain budget number. So, but that was a bigger number. That was our biggest month. Usually it's around a lot smaller than that. And the terms of the contract were listed as 133 last year, and that's what we were paid.
Okay, that's a huge chunk of what that 133 is. So you're saying that you're gonna come forward and ask for additional funding outside of what is currently funded in the contract?
So I'm not expecting that month. So that was a month where we spent a lot of time on the applications, getting the website up, advertising, and I can show you, it's all invoiced. Maybe in a meeting, I can show you the exact spend. But I think what I was planning to do, and I talked to Amanda about it, talked offline with DA Allen, was come up with what I think is a proposed contract based on the changes from the original SOW.
Okay, I guess I'm a little surprised because I thought everything that we had been doing and having the conversation on the website when it came up, that was all under the current scope of work.
So I can
You're
show you.
saying there are things that were under there, were not under the current scope of work?
Correct, and I did not charge for that amount, I just lived up to the terms of the contract last year, so I can show you these terms, and you can make a decision if you want me to stop doing these things or do these things.
Okay, yeah, I definitely would love to see that, and I think, I'd be interested in what other folks' thoughts are, but I think we need to be very clear when we're going outside of that scope of work, if that makes sense. Because if we're asking you to do things that you don't think are within the current scope of work, we probably need to know that in essence, if we are giving direction and not understanding that we are giving direction to spend additional money, and to me, it feels like if we're going outside of that, I don't know what the lawyer would say either, but we need to have clarity that we are spending additional money when we're giving that direction.
Yeah, and just a point of clarification on that, I don't have the authority to spend any additional money. Chair has given me permission to sign off on invoices up to the contracted amount that you all agreed to. And so even if additional funds were billed, I would not have the authority to spend that. So nothing is being spent at this point, but it would be billed.
Yeah, I guess maybe, and I wouldn't put it on the contract, because I guess that's what it is. If we haven't authorized outside of that scope of work, I guess that's where I'm starting to get a little nervous, that if we have inadvertently authorized outside of that scope, but we haven't actually taken a vote on that or understood that was happening. I just would like very clear on how we're going to deal with that in the future. So in addition to what you're saying has been outside of the scope of work, a process for us clearly making everyone aware of when or what that will look like if we're going outside of that scope in terms of notification. I would think a vote would be actually required to go outside of that, maybe for an expenditure, but I don't know.
So I just want to highlight, there wasn't an additional expenditure, right? So I think if there was an additional expenditure, a vote would be required. So as it stands for the year 2024, I lived up to the terms of the contract without an additional expenditure. And it's my hope to do the same this year. It's just a matter of, that was a heavy month and biggest month, so we haven't exceeded expenditures yet. Now, if you allocated that month for 12 months, do simple math, that would be way past the budget. We'll be able to do that. And I expect July to be another heavy month when all the applications come in and I quickly
But
coordinate.
if it's being billed after the work has already taken place, I guess at that point, you're just taking the risk that we may go, well, you may have done that work, but we didn't agree to it prior to.
And that's what happened last year.
Okay.
Yeah.
Okay,
Yeah.
so we obviously want to avoid that.
Okay, great.
That makes sense.
Did you want the lawyer to weigh in?
Yes, sir.
Actually, I agree with the entire conversation. As far as
I like that legal opinion. Everyone's right.
So if you want, next meeting, I can come back with copies of the contract and go through the contract, if that would be helpful. And then you could bring forward some additional information.
I think that would be valuable inside of that discussion.
Okay.
So that we all are understanding what that looks like.
Okay, perfect. Anybody else? Okay, thank you.
All right, so the next agenda item is a presentation by Colorado State University, Rise Above Colorado Project. And I think, okay.
We'll just have you click through.
Okay.
Or do you want me to click?
We'll click for you.
Okay.
Just give us the head.
Yeah. Thanks.
Everybody, I'm Nate Riggs. I'm the Executive Director of the Colorado State University Prevention Research Center. Thanks for the opportunity for us to give you an update on our year one funded project. We were funded under the Youth Prevention Scope of Work. And we'll talk about what the RFIE called for and the progress that we're making so far. I'd first off, would really like to thank you. So this is my colleague Ken McLennan from Rise Above Colorado. We're partnering on this project with a number of other local partners and state partners. So really want to thank you all for continuing to prioritize youth prevention. We know that you, sorry. Again. We know that if prevention is done right, that it can save lives and it can do so in a very cost-effective way. So that really does tie in really well with your RFIE. In order to do prevention right, we need to know what the problems are in data, and then know what our community assets are, our community partners that can implement ideally evidence-based prevention programs. And so, next one. These were the three main tasks that were asked for, the deliverables that were asked for in the RFIE for last year. And these first two are really around gathering that data. Gathering data about data, what data are out there that can help inform us and our priorities for preventing substance misuse and other youth risk behaviors. The second one being identifying those local agencies that we can partner with. They can be the delivery systems for implementing these evidence-based programs. And then the third ask from the RFIE was to really start to develop and implement a plan for using the data that we identify in priorities 1 and 2, so that we can then start to deliver those programs. Next slide, please.
So you enjoyed our conversation about that data?
It was, yeah. Well, as a university researcher, I appreciate the data, absolutely. We're all about making data informed decisions here. These are some of our local partners. We partnered with Teller County Public Health. We've partnered with El Paso County Public Health, Teller County Mental Health Alliance, and University Extension in both Teller County and El Paso County. All these partners have been really critical to the work that's been done so far. And then the Prevention Research Center, Rise Above, and then our colleagues at ST2. Next slide, please. So to address those three main asks from the RFIE, we identified 4 goals that really map onto that. The first is to identify what those data sources are, identify what those community-based organizations are that are prevention-oriented, that we can start to deliver programming in, and then synthesize those data. So what we did to collect the data, we have a live file where we're logging all of that information, and we will continue to update it, and we'll hopefully continue to update it over the years. And then our strategy for synthesizing these data are around creating needs, resource, and gap analyses, assessments, and I'll talk about what those look like. Kent and his team are working on raising opioid and fentanyl overdose awareness.
both in schools and using a community-wide media campaign. And then, so this is really getting a broad reach of information out to youth for prevention purposes. And then we at the CSU Prevention Research Center, our plan was to work with 2 to 4 local organizations and really dig deep to start to implement programs and our approach to preventing substance misuse and other risk behaviors. Next slide. Okay, so goals 1 and 2, this prevention needs, resource, and gaps analysis. That slide's just the picture. So we'll go through here. We did have some delays, unfortunately, administrative red tape, mostly on the CSU side, not yet used to the rhythms of these opioid settlement funds and how they're distributed. Took a little while to get going. Luckily, what we had proposed was a 12-month scope of work. So getting started a little bit later was we wanted to start early, but we do have a little bit more of a runway given the 18-month period. So we started with Teller County's needs, resource, and gaps assessment. The deliverables for this, what we're going to do is we on Monday will be delivering these 2 documents here. One is a needs, resource, gaps assessment that is very detailed. It probably won't fit within Michelle's word limit from our earlier conversation. It really does go into really deep detail on the process, all the data that we tried to identify, all the data that we did identify, strengths and weaknesses of those data. It is currently, after a few edits, we got it down to about 45 pages. So there's that, but it really does provide a lot of detail because there was a lot of work. There is a lot of work that goes into this. We also have a version 2 that's a little bit more illustrative, shorter, won't put you to sleep. If that's and if you go back really quickly, one of the things that wasn't in our scope of work, but after we were funded, we identified a unit on campus at CSU called CSU Centroid, kind of a weird name, but they are GIS, I always get that mixed up. GIS mapping unit on campus that will allow us to map our community resources, those prevention delivery systems, on top of as granular of data as we can have on a GIS map. And then, you know, it can be a living document. We can continue to update it as long as we are funded by you all, and then we can hand it over to you and all that good stuff. So, so that's just kind of an extra cherry on top there. Next one, please. Okay, these are the data sources. I won't go into too much detail. I know that we don't have a ton of time, but what we really wanted to do was identify and synthesize existing secondary data sources. So things like CDE data, as recent of Healthy Kids Colorado data as we could find, as we'll talk about, not that recent, and there are other limitations to it, but as many kind of these existing data sources on substance use and associated risk and protective factors. We also wanted to acknowledge and use for corroborating information other existing needs assessments that have been done in this area. And so most of them have been done with adults, but some of the messages, some of the key takeaways and some of the recommendations ended up being somewhat consistent, at least in some cases. So we wanted to acknowledge that. We also felt that community voice is super important, especially in the absence of secondary data, the empirical data that we'll talk about. And so we did focus groups in Teller County and El Paso County to get a sense of what community members across a broad cross-section of community sectors felt were the highest priorities and some good agencies to partner with moving forward. And then finally, we got a lot of other community input in that we started this data set of data and youth serving organizations, but we recognize that local community is also going to be aware and more aware of organizations and data that we may have missed. And so we push that out through people that we know, as well as people who were in our focus groups to help complete that data. And again, it's going to continue to be a living document that can be updated. All right, next slide. These are just the participants, not just, I mean, Michelle, of course. These are the participants that were in our focus groups. This is just simply to illustrate that we had folks from public agencies, school districts, and other prevention-related agencies to provide feedback to us and that community voice. Slide. Here are the key takeaways, and this is going to be a common thread throughout all the data that we collected, is that there's really not a lot of reliable data around youth opioid use and even youth substance use and other risk behaviors. So there's that. There was a sentiment among the focus group participants that we should be focusing on treatment early on, but then increase investments in prevention over time. There's a lot of really committed, or not a lot, maybe a number of really committed folks that are doing a lot in Teller County, and that there's a desire for more community input and engagement. That our prevention efforts should not only focus on youth, but also on families. And then that there's a couple of barriers to the implementation of prevention that are not uncommon in more rural counties. And that is the transportation and distance is an issue of getting to services, as well as stigma is a barrier. When you're in a small community where many people know who you are, there's a stigma if you pull up with your truck to a mental health agency. And so just that helped inform some of the recommendations that we ended up making it with the report. All right, slide please. Again, available, these are key takeaways from the entire report. Again, substance use data are not recent. They're really, a lot of the bigger data sets are aggregated with other counties, neighboring counties in the area of Teller. Teller is the school districts are small enough that a lot of the data are suppressed for confidentiality concerns. And so the empirical data was not as available as we had hoped, but we were able to identify that youth opioid use typically, as you might anticipate, doesn't really. Very few youth are using intentionally opioids. They're more likely to be involved with opioids indirectly through family members and other adults in their neighborhood. This is the barriers, and then this really was around this really high levels of community cohesion and engagement that can be leveraged for youth serving prevention activities. And then the most recent data that we could find that both school districts in Teller County completed was 2019. Healthy Kids Colorado data. So there's a huge caveat there with these conclusions, but we found that there was lower alcohol and cannabis use in Teller County youth compared to state averages, but higher nicotine and prescription pain medication use without a prescription. So there's that there's elevated suicidal thoughts and behaviors in Teller County, that there's lower, this is CDE data and more recent data. So lower school attendance, higher reports of not liking school and high dropout rates. So both of these are not necessarily substance use, but two things that are very highly correlated with youth substance use that we want to keep our eyes on. And then finally, although there were some elevated rates of substance use among the youth, across the board, you typically agree that it's wrong for a young person to be using substances. So this really opens the door to leverage those norms for social norming campaigns like the ones that Kent and other colleagues that our other partners are creating. Okay, so next slide. This is a map. It's not the GIS map, but it is a map of the local organizations. And again, these are prevention delivery organizations. So there are other youth serving agencies that we have listed that aren't necessarily prevention delivery systems, at least right now. This is Northern Teller. So the idea, the RFIE asked for a regionally tailored approach to this. So we did reports for Teller County, and we're in the process of doing a report for El Paso County. And then even within the counties, we're drilling down into regions. In Teller County,
basically what the focus groups told us is that there's two. There's Northern Teller and there's Southern Teller. This is Northern Teller, and these are the prevention assets in Northern Teller. The ones in the reddish color are schools. The ones in the blue, are not schools. And so you've got these really in the Woodland Park area, and then over here in Divide. And then this is a link to the spreadsheet of all the data and all the youth serving agencies. This is really the DNA of the RFIE right here, the list. This is the meat. The reports are really the meat around that DNA that are gonna really describe how we came to this, how we synthesize the data. And next slide. So that's Northern Teller. This is Southern Teller. As you can see, fewer prevention-related services, but also more proximal to Colorado Springs. Okay, next slide. That was a map of youth serving agencies, prevention agencies with a physical address in Teller County. These folks over here are, oh, whoops, there's a little formatting issue there, but these folks over here don't have a physical address, but nonetheless do some youth prevention programming and people that we can partner with. And then these are some folks that came up in the focus groups and in our other data pushes that agencies that came up and upon review aren't necessarily, at least currently, providing prevention services, but we wanted to acknowledge that these agencies do exist and might be future partners for prevention. Okay, next slide. All right, so the recommendations really for the report from Teller County are that given the Healthy Kids Colorado data and some of the CDE data that we were able to glean around substance misuse, suspensions and things like that, that we really want, the data are telling us to focus on nicotine, prescription opioid use prevention, mental health promotion, and school connectedness. Those were the four things that kind of raised to the top in terms of being more higher levels than the state average. And then the second recommendation is to, yes, of course, work with schools and school districts to the extent that we can. Those relationships take a lot of time to build and cultivate, of course. But there are also other assets like after school programs, home visitation or telehealth prevention that could be leveraged given some of the barriers around the transportation and things like that. Okay, next slide. One of the things that really stood out strong, really clearly in our data is that there's really strong connections around within the prevention serving organizations in Teller County, and we can really leverage that really strong cohesion. And then finally, and I know that this is a touchy subject, right? Collecting data is a touchy subject. We recognize that, but I think we would be remiss given the RFIE and the power of those data to really guide our prevention priorities to do the best that we can in establishing standardized community-wide metrics and data collection procedures. Okay, next slide. So right now what we're doing, we even got a little bit of a later start in El Paso County. We found out after we were funded that El Paso County Health wanted us to come in and give a presentation so that they could sign off on their staff working with us. Took a few months to get us on the docket. And so this work really started in January. So we're about halfway done with the process for the needs assessment in El Paso County. Next slide. So we've done the focus groups. We did 3 of them. These are the folks in 1 and 2. Next slide, please. These are the folks in focus group 3. So a really broad, wide cross-section of agencies. Okay, next slide, please. We've completed those focus groups. We've identified most of the youth serving agencies and we've identified most of the data sources. El Paso County Health has been awesome and really worked really hard to identify both of these right here. We're coding the focus groups and we're now in the process of synthesizing those data and cloning what we did for the Teller County. So we'll hopefully have that report done in the next 2 to 3 months. Okay. And I think that leaves me with
Yeah, I'll take over for goal 3 and then pass it back to Nate. I'm Kent McLennan. As Nate said, I'm the executive director for Rise Above Colorado. We're a statewide substance use prevention organization working with youth, primarily middle school and high school age 12 to 17. So we'll talk a little bit about the specific goal 3 around the Connect Effect campaign and the localization effort of that statewide campaign to El Paso and Teller counties. Slide. Just a quick reminder on the Connect Effect. This was a campaign started out of the Attorney General's office, launched in summer of 2023 at a statewide level. We had the opportunity, along with SC2 or other partners in this, to be the agencies that worked with the Department of Law on the creation of that campaign, the building of it, and the nature of the social norms approach that we're taking with this project and with this campaign. And so a quick reminder on the framing around social norms. The idea here is to really combat misperceptions around using data and to be able to kind of debunk the everybody's doing it mentality that may exist around use amongst youth in particular, where the data tells us that most youth aren't using, and we want to communicate that so that we dispel some of those misperceptions. It is an evidence-based approach that's been proven over years. It is a long-term approach. It's not one that happens overnight because we got to change misperceptions before we can impact behaviors. And the last point on there, the more local that data can be, the more likely it is to be believable amongst those young people. Hence why when we're doing this localization effort, we're wanting to talk specifically to youth in Teller County, in El Paso County, and create campaigns that really are representative of those youth. So we'll talk a little bit about how we're getting to that. Next slide. So a few steps of the campaign localization process, where we're at. We'll walk you through a little bit of each of these and where we're headed, starting with data collection. Nate's talked a lot about data collection. Next slide is great, thank you. For this project, we did some additional pieces of data collection, knowing the limitations of the fact that there is no data from Healthy Kids Colorado survey that is recent. And so in our statewide survey that we commission on a biannual basis with an outside researcher, we were able to oversample El Paso County within the 2024 Rise Above Colorado Youth Survey. We had 116 youth from El Paso County that were part of that oversample, and we were using data from those respondents as part of our El Paso specific messaging and how we've kind of gone through and analyzed the data. So we'll talk about, that's all done. All of that's in place, and we have those materials ready, and we were using those in the focus groups I'll talk about in a second. Teller County, again, even more limitations and challenges. A huge shout out to Michelle and folks, Ashley Shields at Mental Health Alliance of Teller County, that really helped us create a data sample with Teller County youth that didn't exist, that we were able to get 80 responses through this, a subset of this larger survey that's sort of already been vetted and done. We had our same researcher work on it and deliver it, and they were able to, through partnerships with some schools in Teller County, able to get us some of those responses, which is great. So we actually have some data that we can use and work with in this campaign. So that just finished collection in February. So we were able to get it analyzed, and we have that to be able to inform our focus groups. So next slide there. So our next step was to take some of these data findings and the concepts of it to local discussion groups with youth. And so we have conducted one, actually two in El Paso County already through partnership with the Pet Boys and Girls Clubs. We had 11 youth that participated in those discussion groups to really give us input on what resonated and what doesn't amongst the data, so that we can then be able to make a more educated decision about what messages we want to highlight and what we want to choose to elevate in this campaign once it goes live. We will be doing Teller County discussion groups next week remotely to be able to capture that Teller County information. And so that is sort of the next phase that will then help inform the messaging development. If we go to the next slide, I want to give you a sample just as a reference point, since you may not have seen it. There's posters downstairs as you walked in here today of the statewide Connect Effect campaign that are still up. I'm glad to see. But I wanted to share with you from a Larimer County perspective, who also through their ROAC worked to localize this campaign. They're a little bit further ahead. This campaign launched in December, but give you a sample of what they did. The base creative is going to stay effectively the same because this is something that we tested as part of that statewide campaign, but the messages change and the images change. And so those are the things that are being localized. So this gives you a couple of samples of particular data points that Larimer County wanted to promote, and that the data really told us these are the things, and the youth verified these are the things we ought to be promoting. So this just gives you a couple of examples of things about sort of bystander behavior to stop a friend from misusing pills that might be laced with fentanyl, and then some other data points about, you know, combating stress without using substances is one of the other things that the youth really elevated. So that's an example of what we're doing in Larimer County and sort of the path where this is headed. Not necessarily the data where it's headed though. So where we are today and getting ready to launch this campaign, our goal is to launch the campaign by late May. So we've got a couple of months between now and then. Once we finish the focus groups, those discussion groups, we are then getting ready for message creation to say, these are, like the slide I just showed you, these are the messages that we are recommending based on what the data is telling us and based on what the youth said that we were recommending for promotion in the campaign and the paid advertising. So what we'd love to just get input from you all on, and James and I have been trying to connect and want to talk about how to facilitate for and with you input so that you all get a chance to see those messages before they end up getting blasted out and the campaign goes live, so that you're aware of what's coming and that you feel good about it. We obviously are meeting on a monthly basis regularly with our partners at El Paso Public Health, with Michelle and the Teller County teams. And so we're getting their input and involvement on a more granular basis, but we want to really understand from you all how you want to be communicated with in the timeline to try to stay on track, but be able to get this going by the end of May, and then running basically through the end of this grant period into December. And this gives you a sample of where we're going to see some of that happen with online, Snapchat, TikTok, YouTube, and then poster placements that will go into youth serving agencies and organizations. Yes.
So I'm a retailer, so I try to pay attention to when I have customers and then direct promotion things around those areas. Was there data tracking on when are you more likely to use during the season or year, and when are they less likely? I mean, would there be a key opportunity to pivot or use advertising or whatever in those key times? Because summer use increased or decreased. I mean, you're gonna start in the summer. I kind of, in my mind, it's like, oh, maybe that's not a good time, but I don't know. I don't know the data. So is that, is there a seasonality to use?
I don't know if that's one that you, just from any data collection that you would want to tackle. I would say not necessarily, and we don't track it at that granular of a level. We do try to collect survey data at the same time of year every time. So that survey I referenced, the Rise Above Colorado Youth Survey, always gets collected in the spring. So as opposed to collecting it at different times of year, you might get, then the data is not very comparable. So can there be fluctuations? Yes. Is there more available time? And in summertime, yes. I think we could make an assumption to say that that's an ideal time where youth may have more time and maybe on their phones and devices more often because they're out of school and may have more of that opportunity for that messaging to hit home. So from that perspective, we think summer's a great time from a messaging perspective. However, there's also value in during the school year in the partnerships that we can develop and hope to develop with schools where we can, again, reinforce this messaging, where posters might be in places that they'll see during the school year that might be different than summertime. It's a great question. And I didn't totally answer it, but I think it's relevant.
I mean, I think the option would be that it may depend on the dissemination channel. Like with the TikTok and Snapchat, probably more uptake during the summer. But in the schools, probably more uptake. They're gonna see the posters and those kind of things in the schools. I think the nice thing about this timeline is that you're gonna get the best of kind of both worlds there. You're gonna get a summer release that's gonna be great for TikTok and Snapchat and YouTube. And then the last 4 months or so in schools and other community organizations.
I think a lot of our schools are going to no cell phones during class.
Yeah.
So,
It's great.
yay. But, so obviously decreased use likely during the school season. I can see maybe increased use during the summer because, that's my comment. I just saw May and I went, wait, everyone's out of school.
Yeah.
Well, maybe they're more in school, but then I didn't know if you looked at, you're talking data to me, so I thought you'd have it.
Yeah. And we can talk about this. We have similar considerations for, goal 4 in that, we're gonna be working with 2 to 4 organizations. Ideally, some of those will be school districts. With the timing, schools are gonna be going offline here in another month, right? And so our approach has been to kind of move up our timeline, to start engaging with schools, even before we completed phase 1, which is the needs and resource assessment. Yeah, sometimes the timing isn't ideal, but we have ways to work around.
You mentioned the oversampling in a previous slide. Can you define what you mean by oversampling?
Yeah, so in the case of the El Paso County survey, that oversample was a part of a statewide survey. So we collected statewide data for about 900 participants around the state to create a statewide sample. Yet in the communities where we are working more and doing some specific initiatives, including this one, we made sure that if the original sample didn't collect enough to have some statistically significant ways to utilize the data so that the margin of error was not too large and that we could actually make some statistical comparisons between El Paso County and the state as a whole, that kind of thing. That's what we were looking for. So that's where we got, where we had 116 respondents for El Paso County. And that was part of that large 900 person collection. So a good representation there where we could work with that data.
So follow-up question. So then where is this Rise Above Colorado survey being administered?
Yeah.
How are you getting it out? I know the Healthy Kids was, we've talked a lot about this, the group I'm part of, that not every school district does the Healthy Kids, as we know. Many opt out. There's some honesty questions about that as well, if they're really being true. Where are you guys using the Rise Above Colorado?
We have been collecting that always outside of school, and we've been doing it for the last 3 samples, almost exclusively online. So social media recruitment, online panels where youth whose parents support them to be able to participate in a variety of different surveys on things. So we collect, the researchers collect through those means. And so we've done that for multiple surveys now. So we're kind of seeing, and it really hasn't changed much of the trends from the old days of phone surveys, but we have always done it outside school, which allows us to get youth that are not necessarily in school, youth that are in private schools, youth that are homeschooled, and it's not based on can we get a school's participation or not.
And then real quick, when you talk about localizing the Connect Effect campaign, which I think is incredible, I love social norming and how impactful that is. Are you using the Rise Above survey to localize? Like, do you use that for the social norming messaging?
Yes.
Okay.
Yes, so that data that we're talking about within that survey, we have specific questions from like the Larimer example that I gave you of some of those data points. Those were data points of questions that were asked. And so we did a subset, not as full a survey with Teller because we wanted to be able to get it done and not, with the kids that were able to do it. But yeah, we're getting at all the topical areas around opioids, around fentanyl, perceived risks around that, bystander behavior, those kinds of things that we can then use as our option for messaging.
Thank you.
Yeah. Ma'am, did you have a question?
I was just curious if there was data that you collected and communities that have that have legalized recreational marijuana based on our communities that don't, because at this point, up until this point, we did, and that messaging would be very different. And I know it's not opioids, but it's the gateway. We've heard many kids come in here and say it is the gateway, and I do believe it is the gateway, so it's very important. And back to one of your slides, it did say on the norms, perception is important because if it's kids based on perception and availability, and whenever the perception is, it's okay because we legalized it and then we have more availability, there is an impact to that community.
Yeah, I will just say from the discussion groups and some of the things that came out of that question about normalization and marijuana use was one of the discussion items that came up with those youth at the Boys and Girls Clubs about the perceived normal, it's available over the counter in their minds, so it must be safer, and treating it sort of like alcohol. So they were definitely drawing a line between sort of alcohol and marijuana and other, what they call harder substances in their minds and the way they treated it.
So would that be in your messaging, that's not necessarily true?
We will probably try to continue to focus specifically on the opioid piece of this. Now, we at Rise Above push data out statewide about the fact that most youth aren't using, and use specific data points from that survey about marijuana, about alcohol, about prescription drugs and those sorts of things. So we'll do that more statewide, but this campaign staying pretty focused around the scope, around the opioid awareness and fentanyl particularly.
Thank you.
Yeah. Yeah.
So it's a really important connection, and we do have a separate RFP that's gonna focus in on the recreational marijuana stuff, so hopefully we can be aware of that and make sure that those two work together in some way and really make that connection. Because I think that is a very important change coming to this community that could impact these numbers very specifically. I am curious though, on the maps in the beginning, you showed those intervention organizations, obviously schools being one, some other agencies. I'm curious, when we think about folks that we may not specifically think about as youth intervention, but how they're talking about the Boys and Girls Club, what about churches? I don't see anything about churches, and I think it's a huge place that kids get reached. Though we might think that that's not an important place to talk about these things. I would tell you that my brother started doing drugs with church friends. So that's something that I actually think is maybe a little bit of a gap that maybe isn't outside or, inside of what we would normally think about youth agents, but they're interacting with kids all the time. So just a thought of some organizations that we might want to reach out to.
That's great. I appreciate it. And I don't know whether that's something that they're looking at in faith-based.
We've had some conversation about that with the goal for, that's gonna be about, finding these agencies, these organizations, faith-based or school-based, that can be great settings for phase 2 of this project and working with those systems. So, yeah, I think that's a great point. I know we've got a couple more slides and maybe come back to any kind of directional piece, because I know we're probably running out of time.
Yeah, a little over, but why don't you finish the slides and we can come back to it. And then just to set it up, part of what Commissioner Stone had asked was that we start bringing formally awarded presenters here. So I think at the end, we'll decide if you want to do that. We can have other awardees present. I think in the past, we've had those who weren't awardees present as well, but I think the thought was Commissioner Stone wanted to move to that. And then this group, just to set the record, was received $659,000 in the first round of funding. So I think as we think about approving their message or letting them proceed on their own, I want to have that in mind as you think about next steps for this group.
Okay, we can go next. Let's go to the next slide. We'll get that last pieces here quickly. Next slide.
Okay, so just as you all probably remember this, but goals 1 and 2 were considered the first phase of the RFI, so collecting the data on the organizations and the data that was approximately the first half of the funding cycle, and then approximately the second half of the funding cycle are goals 3 and goals 4. So we're now initiating, actually we got ahead of schedule with this process in
really identifying who those partners can be, that the CSU Prevention Research Center can work with in really trying to elevate evidence-based substance use prevention programs. This is our model for doing that. I won't get into it in too much detail, but it basically ranges from online research to practice tools, guidebooks, things like that, to two-day-long prevention trainings for practitioners, people, school districts that are doing prevention, to really rolling up our sleeves with individual community partners and working alongside them as they're making decisions related to youth prevention. And ideally, the goal is to get to that third level with this funding process. So what we've done, and I can get through this pretty quickly if we want to go to the next slide. These are the groups that we've started this process with in Teller County. We've got some folks that were part of our focus groups. These are the folks that we've reached out to engage with. These are the folks who we had initial meetings with. And then these are the Teller County CSU Extension is a group that we started initial efforts in working with 4-H, which is the largest network of youth serving. It's the largest youth serving network in the nation. And so a great opportunity to implement some prevention messaging in through that system. So that's in Teller County. And then so we're continuing with these, well, with all four of these folks. And then next slide. These are folks that we've identified through focus groups. Again, a list of school districts down here and other agencies. We've reached out to all of them. Had meetings with many of them, and we started initial efforts with several of them as well. And so, we propose to work with between 2 and 4. If we have the capacity to work with more than that, then we will. We also are hoping to build a deep bench of folks to work with us in the future as well. If we're fortunate enough to be funded in future years, it does take time to build those relationships and that trust with schools. And so, it's a process that we are currently working through. And so these are likely folks. And this is really, some examples here really highlight the importance of doing those focus groups, because we weren't aware of some of these groups. And then during these focus groups, people were like, hey, you gotta think about these folks. You gotta work with these folks. You gotta connect with these folks. And we're starting to actually do that with some of the folks for phase 2 of this project. I think that might be it. Oh, no, future directions. We're gonna transfer all those data onto the GIS map. The data file with all the data and the school district and the prevention agencies, as well as that GIS map, again, living documents, continue to work with them. And then we're going to continue to engage with the youth focused prevention agencies for phase 2 of this project, and then hopefully in future years of funding. And then Kent and others are going to continue to leverage that connect effect messaging for opportunities to provide youth prevention messages. So, and now I think that's it. We have one more slide of the CSU right.
Any additional questions for our presenters? Hearing none, they did have that outstanding question. I'll go back to that slide of whether or not you wanted to be involved in the messaging. So maybe you can talk about what you've done historically and what you're interested in speaking.
Yeah, and I really, again, this is you drive this. I mean, we have worked with partners locally in Larimer County where they kind of vetted our message. We'd be happy to continue to work with our public health partners that we are regularly meeting with on the messaging and the approval of that. But we're also happy, if when we come back with messaging document, if there was a subset or a group that either facilitated through James and Initium or with a couple of you all that want to say, yeah, I'd like to see that before this ends up in our community, feel like you all put the money into this. So it's, certainly we want that input and in your knowledge base, then we can walk through some of the rationale. Yes, sir.
So I heard early on that there was struggle getting data, which I can understand that. We've heard that like all day long. But as you are in other communities, is there a piece or a connection to this that you could inform us on things that we should try to insist on or try to encourage or help us or guide us in asking the people that we're looking to get involved in all this that hey, these are the type of data questions we need, so that they actually inform your Pikes, you see, what are you getting in Laramie County and you're not getting from us? You know, or things like that. Is there an opportunity for that type of?
Yeah, these conversations are so layered, and have become, even more sensitive topics, right? In an ideal world, from our perspective, and I realize that we are one perspective in this room, is that we have data that are similar to something like the Healthy Kids Colorado survey that has, and given the limitations of it, it may not be 100% valid, but at least those data can inform where the community-specific substance use-related challenges are and where they're not, and where we can focus those priorities. I completely recognize the issues around collecting data with kids and parents and school districts and things like that. So if something like that would be really helpful in guiding our efforts. Now, I know that I don't know if there are CTC representation here. Anybody? No, El Paso County has a CTC coalition. They do have a CTC survey of youth risk and protective factors. So if Healthy Kids Colorado is a non-starter, which I imagine is the case in many school districts here, alternatives like a Communities That Care youth survey that maybe could be delivered or with input from the community could be something. It could be a secondary source.
And honestly, that's why we created the Rise Above Colorado Youth Survey in the first place and started being able to collect that sort of on our own terms, reaching youth in a different method than schools and people. And so that's, why we have that kind of data, because in absence of others, it gives us some really good things to work with on a campaign like this and looking at issues more broadly. So we'd be happy to share more of the data findings from what we oversampled out of El Paso and what we have in that sort of truncated survey in Teller as well, to say, here's some of the findings that we did see, right? And yes, it's 116 people. Yes, it's 80 people, but gives us a place to start with and the ways to make some statements about what we're seeing sort of trend wise in these counties. So yeah, we'd happy to geek out on that.
I was gonna say, yeah, how do we get that information? Because I think that would be valuable. And then if I could, I'll take a little bit of liberty. I can say things really quickly. Yeah. The reality is that, being very well involved with the school districts, myself, I can tell you the problem is that the state of Colorado has overreached so far into families and to not, acknowledging parents' rights that the survey got out of hand and parents put their foot down. And so I think it's a really important message to us on that, which is I think that some of these questions, it would be great if we could ask them. And so it reminds us that we need to be careful about how far we go. We need to be aware of how the questions that we are asking affect these families, because it is a situation where I think we could continue to ask many of these questions if the state of Colorado had been respectful to families and parents, and that didn't happen. That's my perception. Certainly others have, others have others, but that is my perception from the folks that I know very specifically involved in getting those surveys out of schools, is where they're coming from. So it's very important as we look at this messaging. I would love to be involved in saying that. I've been very vocal in this group about some of that messaging. If it is the wrong messaging, you will be counterproductive in trying to get to these kids because parents do not trust the state of Colorado. Specifically, we have laws that have basically taken parents out of the equation in a lot of situations. So, my soapbox.
Well, I agree with that. Could there be an opportunity or something that we could reshape, or maybe it's something that we do within our group here, that we create our own surveys that is a different, and get some authority behind it or something like that.
I was actually gonna suggest that, collectively, we have years of experience in survey development, psychometric properties, all these things that we could geek out with you, sampling and things like that.
Yeah, if this council was interested in partnering with our organizations in thinking through how we might be able to create something that's more palatable to parents, to schools, to you all. That personally, as a researcher, that would be really fun. And so, so just maybe a bug in an ear. And I know that would probably be a long conversation in kind of creating your vision for that, but that'll be something I'm super excited about.
I'll say, like, Michelle and I and Deanne have already had a lot of these conversations around exactly that, and I know I'm open to that, and I've already talked to some of our school board members and folks that were very much against Healthy Kids about whether or not they would be open to having a conversation and saying, we're gonna be transparent, we don't wanna do those things, so I think that is a great thing, that we could do, and maybe, I don't know much about the RISE survey yet, but I'd like to learn more about it, because maybe that is a really good starting point to what we can do, and it would take a lot of relationship building. But I think that there are a lot of people in this room who don't have a lot of those relationships, and we might be able to help that. I actually think.
Yeah, it goes with our mental health. Rising, our mental health initiative.
I wonder if it could also be a model for other communities around Colorado and even nationally to follow. Like, this top-down approach is clearly not working. Are there other more grassroots or community engaged approaches to gathering the minimal amount of data that we need that is also actionable to make change in young people's lives, or at least lead to efforts that will make change in young people's lives, not overreaching, not asking the same question a million different ways, and asking questions that aren't going to inform our priorities. That could be pretty interesting, I think.
So can you guys share the data from that oversampling with the council of what questions did you ask? What were the responses? And then net it out, sanitize it if you have to, but I'd like to hear what you're asking and how people are responding, because that's a really small sample size.
Yep.
So if you'll send that data to me, I'll send it to the council.
Great.
I think the outstanding question remains, as we're kind of at the end of the time, how would the council like to look at their messaging? And then maybe you can just make sure they're clear on the timing of your campaign. They want to perhaps review it without impacting the launch date.
Yeah, so we'd be looking at, by the end of April time period of having messages that we can then approve to be able to create the assets and everything to get ready for launching paid ads by the end of May. So, yeah, and it's a message development. You've seen the creative it's that shell, it's the message and a lot of local youth and pictured in some of these as opposed to others from other communities. So, yeah.
So if the group agrees, I will get the information maybe a couple of weeks before the April 23rd meeting and then invite them back. And get the information in advance and invite them back to share that messaging so it can be approved prior to going out throughout the communities with the funds that you've invested.
That sounds great.
Okay.
Great. Thank you.
Thank you for your time.
Perfect. Thank you. Appreciate it.
We're gonna go to the final agenda item. Right before that, I want to make sure that the group understands that again, Commissioner Stone was asking for this type of presentation as opposed to the general outreach to the community to present. So I wanted to make sure the group found this useful and would you like to move in this way where the groups you funded get to come and present like they did today?
I think it's helpful. Yeah.
Yeah, okay, great. Then another way to monitor.
Gives us confidence in how we're spending money.
Absolutely. Okay.
No,
Sorry. Love that.
I have people in the building with handcuffs and these guys. Yeah.
No, but no, truly, a couple of things. I thought it was particularly helpful to have this youth presentation because we're going to be hearing those youth things next week. So I really appreciate the timing on that. However, on the other hand, there has been conversation, and I don't know where we are in the process of having Dr. Talk specifically about Matt Mood and the use of that in an overall strategy, and what that, and I'm really curious about that. I wish we had gotten that presentation before the Matt Mood applications, because I think that could have been valuable and informed. So too late to go back and do that, but I wanted to say I like the youth one, and if we could keep up that kind of pattern, if we have folks that can do presentations that are if we can line them up with having them before we see those applications, that might be a really good informative way to help us make decisions.
Okay, yeah, I'll take that offline. I guess, just want to be clear, because we opened up the doors to a lot of community group coming to present, there was a long line now. So we'd be shifting our goals to, prioritizing those we previously funded and then coming to the larger community at large, still letting them present. That's, I guess, my ask, because there's a line now.
How are you selecting those that present?
By schedule, and like Dr. Bronski's been on the agenda for a while. This took a while. Michelle's group was on the agenda. There's another group. There's a bunch of groups now that are in line to present.
Could I just ask the chair maybe to ask those questions and you guys?
Maybe you can ask me.
Rather than just saying, these signed up in these order, you guys are smart people. I trust that you can do that, but if there are people that would make sense to put into that order, to maybe consider that as we move forward.
Yeah, I think James and I had a conversation about that.
Yeah, yes, and I think, what Maya was just mentioning was the order that we had of the different question. The order of the groups that we, shared was in order of how they were initially scored. So you are
Based on
getting,
scoring.
correct, so you are getting that first round of groups outside of us swapping out CASA in the order that they were awarded. Okay.
Yep.
First scored. Okay, so last agenda item is the, public comments. So with that, we open it up to the public. We just asked you to come up front if you're going to speak.
Becoming a familiar face for you. Beth Rolstad from Homeward Pikes Peak. My question is, do you have a schedule of when other statement of work areas will be scheduled so that we can prepare for when we might be called for presentations?
Yes, it shifted after today, and what we have done is after these meetings is send messages to the groups that are asked to present next month. The way it looks at this point, it'll be a few months out, so I will continue to communicate with the groups, all of them, the 35 that applied, that when their schedule is. Like today, they were scheduled on the time frame. We'll do the same with the 4 groups of the youth prevention sector, but it looks like it's gonna be a couple months out.
Thank you.
Thank you. Any other public comments?
Could you get some Diet Coke? Oh, wow.
James, I agree with the public.
How about it?
Miss my slot. I'll address that to you later.
So 1 Diet Coke for Holly.
Yeah.
Any other final public comments? Okay.
You raise your hand again, Carrie.
Are you gonna turn it back to the chair?
I think we'll adjourn. Thank you, everybody.